Yes, thanks again for coming. My name's Steve Palmer. I'm a professor in health sciences and one of the planning team that includes Cindy Beckett, Nick Beckett, and so thank you. And really today, this is all about Joe. Thank you, Joe, for bringing tremendous speakers together in an amazing program. I just wanted to say that this is funded by the Arizona Biomedical Research Center Education Series funding. And this is the third in a series of 5 workshops that we have held this year. The first one was all about the All of Us Arizona Health Database. The second one was about coordinating addiction services in Arizona for folks with substance abuse disorders. And then we have this one upcoming. We have a 2-day workshop in Yuma that's focusing on rural and border health, including the healthcare workforce development. And then we end the year back here with a conference on the importance of really how to address benefits from surgery it's about surgery and weight and trying to emphasize more strength training and health behavior change rather than focusing on dropping weight before surgery for better surgical outcomes. So anyhow, thank you all. I'm going to turn it over to the brains of the operation for this piece, which is Cindy Beckett. So thank you all.
Thank you. So this is our CME statement that we're required to read. We are offering CMEs for this workshop. Please, if you have pagers are gone, but phones, please put them on silence or vibrate. We have restrooms just right around the corner if you need restrooms. And you'll notice at your chairs or at your tables, there's a little triangle. That's a microphone. So when it's time to ask questions, all you have to do is hit the button, the green light will come on, and we can hear you without having to run the mic around, which makes it very easy. So today's program is epidemiological models and computer simulations to benefit public health. Our objectives are the participants will learn the fundamentals of epidemiological modeling 101 and what these models are and how they are constructed and how they can be useful in the context of public health and the forecasting of infectious disease spread. Participants will hear from academic experts about models, methods used to address real issues in infectious disease. These case studies will highlight national and local issues in infectious disease and how models can be effectively deployed to improve understanding and the planning in public health. And guided discussion sections and panels will allow participants to address questions around the assessments about barriers and opportunities for using the models in their fields. All of our speakers were asked to disclose any conflicts of interest. We had one speaker, and thank you for adding your extra information. The following planners, faculty, or individuals in the control of content of the educational activity have relevant financial relations with ineligible companies. Dr. Sanjay Mehrotra has disclosed that they are principal in Gita Services, Inc., and Stochastic Optimization Technologies, Inc. All of the relevant financial relations listed of these individuals have been mitigated. None of the remaining planners, facilitators, or individuals in control of content of this educational activity have revealed any relevant relationships to disclose in ineligible companies whose primary business in producing, marketing, selling, reselling, and distributing healthcare products used on patients. This is a requirement that I have to read this for CME. At the end of the workshop, there'll be a QR code provided. If you would like to seek CME, all you have to do is scan that and then fill in your information, and you'll have a certificate emailed to you. So with that, I will turn it back over to you, or who's introducing our first, or Joe, are you introducing our first person?
Well, I just want to say thank you for everyone in the room today and for everyone on Zoom for attending, and welcome to our event, which is hosted by the ABRC and CHER. So thank you for that funding. My name is Joe Mihaljevic. I'm an associate professor in the School of Informatics at NAU, and we'll get started today. Because of where we are historically, I want to read this statement. On behalf of Northern Arizona University, we would like to express our gratitude and appreciation to the sacred land on which this educational institution resides. This sacred land is enriched with indigenous history and culture that lives on this day. Currently, the Zuni, Apache, Yavapai, Wallapai, Havasupai, Paiute, Dene, Hopi, Shawanoe, and many other Arizona tribal nations recognize this land as a significant spiritual place. We here at NAU are fortunate to live, work, and share this unique location. I want to thank my colleagues that are a part of a large collaboration that's NIH funded, which we call Epimorph, which I'll talk a little bit more today, but not a ton because this is about educational opportunities. But thank you for being here and looking forward to several of your talks today. And I want to give a special thank you to our travelers and keynote speakers. So we have a great group of speakers, but these folks are traveling in today. And so thank you so much for being here. Appreciate your time. Sanjay's up there somewhere. Thanks, Sanjay. So what are our goals today, and what's the goal of my introductory talk? So I'm not going to be talking a lot about any hardcore science or specific case studies, but I want to give you an introduction to epidemiological modeling and give you kind of like precursor information so that it's easier to digest some of the upcoming talks in this series. So we're going to be talking about modeling, disease forecasting, resource allocation, and the effects of social determinants of health on disease spread. I hope that we can also forge partnerships. We have a lot of people from diverse backgrounds in this room, from public health, academia, tribal nations, health institutions, et cetera. And so I'm hoping that during our outbreak sessions and lunch that we can forge partnerships. And then also this type of experience and educational opportunity helps us in academia develop plans that might be useful for the public health sector. And so we're really looking to receive feedback from you about problems that you're having in the public health sphere that we might be able to assist with. So I'm going to start with my epidemiological modeling 101. So what are these models? So epidemiological models help us explain the spread of infectious disease. And I'm going to use this little schematic diagram to help us understand. So what we see here are that each one of these hexagons is a person, let's say. And so this is a population of individuals. And up here on this graph, we're going to track the number of infected individuals over time. And we're going to insert one infected individual into the population. The rest are not yet infected or susceptible. And then eventually, after infection, people can become immune to the pathogen. So the pathogen will start to spread in the population, and you'll notice that over time, those people that had infection can become immune. And as that infection spreads, we start to see this exponential epidemic outbreak. But then we also start to see the epidemic burnout of the pathogen in the population. And that happens because of this buildup of immune people in the population that become refractory for infection. So we can see that eventually the pathogen should burn out of the population in this, simple example. And so an epi model is a representation of how we believe pathogens transmit within and among populations, like the diagram that I explained. And these models are formalized with mathematical equations, which I know some of the speakers will show and some of them will not. But how is a model actually created? I feel like sometimes people hear the word model and they're like, I don't know what that is or where it comes from. Well, basically, people get together and they come up with ideas and assumptions of how pathogens transmit and what factors might influence disease and the spread of that pathogen. Then, based on historical understandings, we can take these ideas and assumptions and translate them into mathematical equations. And then those equations, if they're complex enough, need to be developed into computer code so that we can solve those models and simulate them. So essentially, models are created by individuals or teams of people. And I think this is important to recognize that, these models come from assumptions of individuals. So now that we have this computer code, we can simulate the model. So simulations might look like this, where we're trying to track over time, what might the infections per week look like in this scenario, or in some other scenario, where these scenarios could be scenarios of intervention or the assumptions of how the disease is spreading over time. So another question that we get a lot is, how is a model made useful for a specific place? So you can build a model that has no information about place in it, just to understand how a pathogen might spread theoretically. But in public health, we want applied problems, right? And so we want to understand, how do we make this useful for a specific place like Flagstaff? Well, in this case, the model must be calibrated and refined. So how do we calibrate a model? Well, we need data. And a lot of you know that this data is hard to collect, and it must be entered into some system. And Steve talked about a previous one of these workshops dealt with, where is the data stored for the state of Arizona and what does that look like? But these data can look like hospitalization events, positive cases that were detected by labs, things like that. So the model needs to be calibrated. So the data that we collect might look like this, where we've collected information on infections per week, and we have data points for our city. And then when we calibrate the model, what we mean is we try to figure out the parameters or the variables in the model that help us best explain those data. So here, this line represents the model match to the data with some error or uncertainty around that model match. And then as more data comes in, this is where we need to refine our models, because sometimes the model no longer matches the data very well. So we have to refine the model assumptions and figure out, how do we improve the model? So this is an iterative process of calibration and refining and talking to your partners about what's going on in the communities and how do we better match what's going on with the mathematics in our models. So this process, if it's done correctly and in a collaborative way, can lead to a useful model. But how can we actually use these useful models? So models can be used in many ways, but I'm going to focus on a few. They can be used for discovery, prediction or forecasting, scenario simulation, and also for understanding resource allocation. So in terms of discovery, we might have questions like, what environmental factors drive infections? So in this case, I'm showing a mosquito-borne pathogen that might be influenced by things like precipitation or temperature in the environment. So we have two environmental factors. And we can build models that include or don't include those factors and see which one matches the data better. And that helps us understand which one of these or both of these factors are important. In terms of prediction, we might want to know, well, what's going to happen in the next few weeks with infections or hospitalizations? And so in this case, we can match our data and our model together and then do a forward projection or forecast with uncertainty to try to understand what might happen in the future. So examples of this happen all the time in academia and in collaboration with the CDC. So during COVID, there was a COVID-19 forecast hub in which I think about a dozen or more teams of academic researchers and public health researchers put together models and tried to do their best to predict over time what would be the daily hospitalizations of COVID. And these lines represent all of the different types of models that were used for prediction. And you can see at this time point, a lot of those models did not do a good job at matching the data, but some of them did. We also have forecast challenges for influenza that are going on right now, actually. So this is the CDC flu site challenge, where they're trying to predict the forecasts of weekly influenza hospitalization admissions in the US and also on a state-by-state basis. And you can see just a small fraction of the teams that produce forecasts. So not only can you forecast these metrics of like hospitalization or disease, but you might also want to forecast where is a pathogen going to spread next, or spread generally over time. And so you might come up with predictions of high probability or low probability spread between locations. And so where might a pathogen spread in the next few weeks? But we might also want longer term forecasts. But in this case, once you're talking about a few months into the future, we typically use the jargon scenario simulation. And that's because it emphasizes that we have much less certainty about what might happen further into the future. So this is just kind of a hypothetical scenario. So for example, these two colored lines represent two different scenarios of, say, intervention. Do we put masks on? Do we distribute more vaccines? What might happen if we did those certain things? You can use the models to simulate those scenarios. So here's an example of a scenario where what might happen if we impose some certain intervention. So we know what has happened up till now, and then we're going to apply an intervention and hopefully see that the pathogen is going to decline over time in the future. So these were put together as an example during the COVID-19 scenario modeling hub, where teams of researchers would come together and not only produce models, but also negotiate what were some realistic scenarios that might happen in the future. And these scenarios were negotiated with public health experts. And so these were modelers collaborating with the CDC, collaborating with other experts in the public health workforce to come up with, well, what do you think might actually be feasible in terms of interventions, and let's model those. Another way we can use models that Dr. Mehrotra is going to talk about is resource allocation. So if you have a limited resource, like vaccines, how do we deploy those limited resources in the most optimized way to control specific outcomes? So if you have a limited number of vaccine points of distribution or pods, or if you have a limited number of vaccines or a limited number of people who can distribute those vaccines, how do we deploy them most effectively? So you can see that we've got lots of ways to use models, but in all these cases, you really need collaboration between the academic modelers and the public health experts. So modeling can provide another layer of quality information to support decision making. I'm not saying that models should be the only source of decision making. I don't think any modeler would say that, but it's just another layer that epidemiologists and other public health workforce can use in decision making. So it can be very useful, but not without some serious challenges as well that we actively work to overcome. So as I showed in this picture, there were lots of models deployed for COVID-19 and for lots of other pathogens. But if you're a public health expert, which model might be best for your jurisdiction? That's not always a straightforward answer, and it really takes some testing to figure that out. Another question that we get a lot with our collaborations in public health is, if we make predictions, say for a county like Coconino County, are those relevant for a specific city like Flagstaff, which is just a small part of our overall community in Coconino County? And how do we make that decision? And moreover, a lot of forecasts are made at the state level. So are those forecasts at the state level very relevant for a city like Flagstaff or Tuba City? So yeah, is the same prediction relevant across these spatial scales? Well, sometimes we don't know, because as modelers, we might not have available data, or even the public health workforce, depending on what sector you're in, you might not have the data to help us calibrate these models. So there's a big question out there, is at the county level, or is this the finest scale that we can make good predictions given data availability? This is something our group is actively working on. There can also be problems with data that's available. So what if data quality or quantity vary across locations and over time? So here's some examples of like place A versus place B, where in place B, you don't have many cases, but you have this weird jump in cases in the middle. And so the question is that an anomaly in the data or is that real? And that's something that we have to grapple with because those can mean very different things in terms of disease spread. So we have all these problems with lots of models. Which one do I use? How do I use these models across different spatial scales? And how do we help maintain data quality and quantity over time? And so this really emphasizes this idea of collaboration in which we need robust models, but also robust data from our public health community. So I just want to emphasize that our group is working on some of these challenges in the Epimorph project, where our vision is that if the data is available, that we can use kind of crowdsourced modeling repositories to discover the best models for specific places and then create local-based forecasts for those places at smaller spatial scales than the county. And then that would also enable for these scenario-based simulations that are specific to certain locations, as well as decision support tools that allow us to figure out things like where should we distribute vaccines. And we just released our first open source software to help the workforce with this, which we call Epimorph because it's in the Python coding language. So thanks, Tyler, for coming up with that. And this allows users to build these spatially explicit modeling all the way down to the census block group level. So a very fine spatial scale for the public health workforce to work on. This is just an example of simulating some models across Arizona counties. And there's a lot of automation built into this software so that it makes it a lot easier for individuals in the community to work on these models and collaborate with us to build models that might be more fine-tuned to your locations. And I think that was the last slide that I had for my presentation. So thanks, everyone. So we are going to have a question session at 11:10, but I'm running ahead of time. So if there are any questions on that presentation, just on the basic information, I'm happy to take one or two questions. Sam.
Thank you, Joe. I was just curious if the CDC is still running the modeling challenge and if that's still happening for flu.
Thanks, Samantha. So yes, the CDC is still running the flu site challenge for the influenza. I don't think there's an ongoing COVID forecast challenge, but I also think there's one for RSV. And there's intermittently ones for West Nile virus, but I don't think there's one active right now. Any other quick questions? Anna?
Epimorph sounds super exciting. I wanted to know a little bit more about what kinds of data can you incorporate. So you know as well as I do, and most people in the room know that, especially at this resolution that you're showing here, data sometimes are opportunistic, right? So how do you reconcile data within Epimorph and what kinds of data do you have?
Yeah, that's a great question of what types of data can we use in Epimorph to try to calibrate our models to specific locations. So right now we have functions in our software that'll allow users to grab publicly available data from the CDC. So this includes historical facility level hospitalizations for flu and COVID. So facility meaning like hospital system that you can aggregate to different spatial scales automatically. So like if you choose your spatial scale to be county, it'll find all the facilities in the county and aggregate it for you. And then I'm trying to remember all of our data sets. So we've got the CDC ones that are publicly available for influenza, COVID, and RSV. And then the user is also able to upload their own data, and we have like helper functions that will help you format your data into the right methodology. And then we have a built-in fitting, so we have a particle filter in there. And we'll tell you more about this later. Yeah. Crystal, can you press your button?
The push button. Yeah. Thanks, Joe. I was wondering, are you planning on putting this into like a web server format so people can access it that way? And I may have missed it because I walked in late, so apologies if I did.
No, you didn't miss it. So that's our next year, is working on a web server or a GUI based approach for this, in which people can see like our epimorph forecasts for these different challenges that are going on, but then also to help build their own forecast and collaborate with us to, if they have data that they want to use, they can like kind of upload that data and use more of a point and click method of coming up with model fits and forecasts.
That's awesome. I think that's really exciting, and it's going to just push the needle forward in this area with Epimorph leading the way.
Thanks, Crystal. Yeah, we're definitely very cognizant of like wanting to get these complex, quantitative approaches in the hands of people that could benefit from it. Okay, I think I'll stop there. And we're a little ahead of time, so I want to introduce our next speaker, Dr. Pamela Martinez, who's coming from the University of Illinois at Urbana-Champaign and is really an up-and-coming leader in the field of modeling and the linkages with social determinants of health. And so I really appreciate you, Pamela, for coming, and looking forward to your talk.
Hello, everybody, and great. And thanks, Joe, for the invitation. It is my pleasure to be here and talk a little bit about our work. I'm going to be talking about COVID, and in particular about the impact of socioeconomic status on disease dynamic and control. So Joe already gave an idea on how infectious diseases are transmitted. So I'll give you a quick overview of our work in my group. So if we think, we can characterize people into susceptible, infected, and recovered. And when we think about what are the factors that are determining that infection status, we can think about pathogen factors, such as how diverse they are, because that is relevant for whether you mount a long-term immune response. There are factors about seasonality. It's not a coincidence that most respiratory infections peak in the winter and not in the summer. And then linked to the seasonality component, there are a lot of environmental factors that are also very relevant for vector-borne diseases, and I think you will hear a little bit more about that later on talks today. But we can also think about host factors, right? And when we think about host, there are differences in age, there are differences in gender or sex, socioeconomic status, and the immune response that these hosts are mounting through time. So today I'll talk a little bit about these host factors, but again, we are also interested in understanding how both hosts and pathogens influence the transmission of diseases. So earlier on in the pandemic, I started my position as a faculty in 2020. And there was this perspective earlier on in which caught my attention, that was thinking clearly about social aspects of disease transmission. And what does that mean, right? Is that we can think that different people have different contact patterns depending on many aspects. And when we just take cases or hospitalizations or like the data that we use to calibrate and fit models, they actually come only from this aspect, right? We don't get to see a lot of these other components of the transmission, but it was very evident, especially with COVID, because of the availability of new data sets, that thinking about this other aspect was also relevant. So they have, there are different aspects. For example, males and females might have different roles in societies and different countries. They might have different jobs, right? Like it was very clear as well that health workers were more exposed to COVID-19 earlier on than, let's say, someone that was able to work remotely. And also there are social aspects that might vary across different cultures, across different race, ethnicities, and socioeconomic status. At the same time, there was this other paper, because I'm a disease modeler, right? And it was like, how is that pre-COVID, very few people have been kind of thinking or addressing these questions about inequity and host factors in infection risk. And I think the reason of that is because there was limited data. There has been a lot of work done in HIV and, like, for example, sexually transmitted diseases historically, because they do have an important host component. But when we think about influenza, for example, there were very few studies thinking on like how these different aspects might play an important role. So I'm going to tell you two different stories of work that we have done in our group. The first one is looking at socioeconomic status on COVID-19 outcomes using data from Santiago, Chile. I'm originally from Chile, and I know how inequity Santiago, the capital, is. So it was kind of relatively easy for me to see right away that there was an issue there with how cases and the response was being developed. And then with that work, we wanted to see what about vaccine uptake and what does it mean in terms of different socioeconomic status. So this first work was in collaboration with Gonzalo Mena, who is a statistician, and then Caroline Bucky and Mauricio Santillana, who are epidemiologists in Boston. So again, where is Chile, right? Chile is a long and skinny country here in South America, has everybody else in the world. They got hit by COVID early in 2020. But Chile is a very interesting country because 1/3 of the population is in Santiago, in the capital. But even though 1/3 of the population is in the capital, the number of cases earlier on were about 55% coming from the capital, and about 65% of the deaths were in the capital. Again, because they started to have a lot of restrictions in terms of movement and international flights. Santiago is the only it's the only city that has an international airport. So all the importations actually came into the capital. And then I'm from Santiago, so I know very well the inequity of like many big cities, right? So if we think about how the city is structured socioeconomically, it's very inequity, like it has a lot of inequity. And there is a factor, in fact, like a metric that is developed by the government to understand this socioeconomic status. So it is a metric that varies from 0 to 100 or 1 to 100. And what I thought was interesting is that not only considers like income aspects and poverty, but also takes into account access and quality of education, health factors such as access to healthcare and life expectancy. So with that, we map, and this is like the metropolitan area in Santiago. So there are 34 municipalities, all classified as urban municipalities. And here in dark red, we see the ones with low SES, which have a very like low index, meaning that those are the more vulnerable populations. And then with dark green, we have the high SES, which are the wealthiest part of the city. And as you can see, most of the wealthiest part of the city are all aggregated in one region. And here's where the Andes is in the capital. So the first question was like, can we infer real incidents, right? Because we got a lot of death cases. And I think that is another characteristic of Chile, that they reported death cases within 7 days. It's mandatory. And they report like 99% of the death. So we have a very accurate information about who was dying from COVID, but cases were not, right? There were not many tests. And therefore, we use this information on like death to try to infer the true incidence that was happening, especially earlier on. And I'm not going to talk about the math details or the technical details, but basically using infection fatality rate from the Diane Princess, and I don't know if you remember, but there was a cruise, thank you. Earlier on that got a lot of people infected and a lot of people died. So that helped a lot of like models and methods to actually parameterize, well, if we have this number of deaths, how many infected individuals we can have. So we knew the onset to death distribution, and we knew the number of deaths. Therefore, we could actually infer the number of infected individuals. So here are our first kind of results. And you can see that on the right y-axis, we have the reported cases that were in the orders of 2,000s to 6,000s, but we were estimating that it was about 5 times higher. And again, this is in 2020, and we are looking at a time between March and August. But something that caught our attention was this, that the cases really didn't peak, but some of the methods we used to infer actually said, well, there was a bump earlier on that wasn't really picked by the true cases. So we went and investigate that. And what we saw is that here, okay, so oops, here I'm missing the axis, but basically this is sorted by SES, where Vitacura is the municipality with highest SES, and then La Pintana is the lowest. And what you see is that cases were imported into the high SES, probably from traveling of these individuals, right, earlier in March. And then a lot of cases, like the official cases, show that there was a little bit of an outbreak in these high SES municipalities. And later in April, it seems that you started to see cases more spread across the city. However, if you now look at the death, right, which are the confirmed death and attributed death based on like symptoms, you see that we saw earlier death like that in places where incidence was relatively low. When we look at tests per 10,000 individuals, we see that these high SES places have much more tests, and that it was, again, not until late that you started to see tests more spread across the city. So if you have more tests, you will find more cases. But again, using this kind of approach to infer the true inference, using the deaths that were observed, we will have seen a very different picture. So now these are the inferred number of cases if we take into account population density and the death observed in these other municipalities. And it's telling us that maybe this outbreak wasn't real, and that maybe, sure, there were earlier cases on, but the cases spread way faster than we thought at the beginning of the pandemic. So to conclude for the first part, right? Earlier first wave of infections occurred in quickly spread through the rest of the city, and that these low SES municipalities were definitely underreported. Okay, so now here, a similar picture looking now instead of earlier in March and April during this first wave of cases. And what we saw is that, again, these are the true cases, not the inferred cases. I mean, the actual reported cases is that there was 5 times higher number of cases in this low SES and about 4 times more death during the peak in this low SES. And that there was kind of an exponential association between your SES status and the number of attributed death. So the second conclusion was that attributed deaths were 4 times higher in these municipalities with low SES compared to the highest SES. We went on, I'm going to show you multiple pieces of data just to kind of highlight the importance of these findings. Then we went to look at movement, right? And again, like data for good from Facebook was openly available, and that was very helpful to understand how mobility was happening and how they were kind of responding to lockdowns. So Santiago had a full lockdown between May and August. And here the colors again reflect the SES status. So dark red is low SES and dark green is high SES. And again, what you can see, right, is that places with high SES were able to comply very well with changes in mobility, while places with low SES were not able. And here I highlight Santiago and Providencia because those were like the city downtowns. And of course, people like work there, and therefore they had like a lower, like the mobility was reduced the most because that's where people go to work. And here, not to say that people with low SES were not compliant because they didn't want to. It was basically because we were unable because of the type of jobs that they have. Like people with high SES were able to work from home, while many people from the lower spectrum were not able to. So again, the conclusion from this is that they were unable to work from home, and therefore they were at a higher disease risk. And maybe that could explain in part why we saw more cases earlier on. Another thing that we did was to look at excess death. And here, these dashed lines, right, are the for the city, for the entire city, the total number of deaths on the past 20 years, right? So you saw that it's very, like, it's seasonal and it's very consistent. So given that information, we predicted what will have happened in 2020 in the absence of the pandemic. And it fitted very well up to like April, May probably. But then we had this huge spike that deviated from the expectation. And the difference between this spike, this peak, and the predicted is what we call excess death. And that actually can provide some information about the true impact of the pandemic on mortality. Something that was interesting, again, from this particular the quality of the data is that when we look at the excess death in gray, they really match the attributed confirmed COVID death. So it highlights how the system in Chile is relatively, well, is very good in reporting the number of deaths on time and accurately. Okay, but what about socioeconomic status and age? So what was interesting is that when we look at now socioeconomics by different age groups, so here we have people between 0 to 40, 40 to 60, 60 to 80, and 80 plus. And then this Z-score is basically a metric of this difference between the predicted and observed cases. One thing that we can highlight is that for 80 plus, it didn't matter, right? Like people on both spectrum, high and low, were dying at similar rates. But it was in younger individuals that we saw a higher difference across the socioeconomic spectrum. And what I thought was more, well, and to conclude, and then I will move on to the second part of this analysis, but that anomalies were higher in more vulnerable areas, particularly in those that were younger than 80 years old. We also found, and I'm not going to show here because of time, because in fact I'm already kind of going very slow, but I wanted to make sure it's clear that positivity and testing delays have been higher in less affluent municipalities, suggesting impaired capacity during the 2020 of the healthcare system. So the last piece in terms of infection fatality rate, right? Again, this is an unfair information about, given that people were infected, what is the rate at which they were dying? We saw that, again, for the 40 plus, this infection fatality rate was relatively flat with respect to socioeconomic status, but there was this is in the log scale, so there was a sharp difference across socioeconomic status. And what we did was to compare the lowest, like we divide these 34 municipalities into 4 quintile, like the lowest SES and then the highest SES and then 2 in the middle. But comparing the lowest with highest, what we found is that even though people with the 0 to 40 were not dying as much from COVID, right? The difference was the highest in that group. And I thought that was kind of striking, because there is a difference, but it's 3 to 4 times higher in the youngest group. So to summarize, people younger than 40 years old had an infection fatality rate that was 3 times higher in the poorer neighborhoods. So this is kind of the summary, and highlights where where this socioeconomic factor might play a role. Is not just in contact. I mean, yes, in contact is the first component, right? That maybe people with high SES were able to stay at home and be more protected than those that maybe have a type of job in which they didn't have that option. But then people in the high SES had rapid access to tests and masks that maybe people in the low SES, and I didn't show this, but we showed that there was a huge delay in getting the results of the test results. If you get it after 7 days, it was meaningless, right? You already infected everybody else. And then hospitalizations were collapsed, hospitals were collapsed in these low SES because there is the capacity is lower per capita individual that in the high SES, where they have also access to private clinics and so on. And then all of that kind of caused this difference in the mortality. Okay, I'm going to move on to the second part, which is now looking at vaccine uptakes. So these plots were everywhere. They were in the New York Times, in Washington Post, and everybody was talking how different countries were vaccinating their population at different rates. So here on the x-axis, you have GDP per capita, and the y-axis, you have population with at least 1 dose, right? And many countries in Africa vaccinated the population less than 50%. And this is in the context is as of June 2022. And then, of course, Europe and North America and we're in the kind of this corner here. So places with higher GDP tend to have higher percentage of population vaccinated against the first dose of SARS-CoV-2. But we had this question, but what about the sub-national level, and changes over time? So a graduate student in my group did a very thorough job in getting vaccine data across the globe. So we were able to get data from a lot of countries in Latin America, in North America, and then places in Europe and Asia. Unfortunately, we only were able to get 1 country from Africa because the data wasn't available, or because it was below the threshold we needed to do our analysis. But with that information, we also disaggregated for Brazil and the US the data at the state or region level. So in the end, we ended up with 81 places from 26 countries, including 33 states of the US and 24 states in Brazil. And then the quantiles, because we split all these locations, given that we had a higher the spatial resolution, we, for example, in the US, based on county level data, we were able to split the states into high and low SES based on income or poverty rates that were available. So something interesting, but maybe not surprising, it was that in 83% of the places, the highest SES group experienced higher rates than the low SES group. And I'm going to zoom in to show you a few examples. So here is Arizona, and here is California. So across all the 81 places we analyzed, California was the one with the highest disparities. So the difference between high and low SES was the highest in here. And interesting, it seems that Arizona, the difference wasn't very significant. And in fact, the low SES was slightly higher than the high SES. But something else caught our attention, and that was the temporal difference. Oops. And here I'm going to use Cape Verde as an example in Africa and Malaysia. So what you can see is that in Cape Verde, people were vaccinated earlier on, very fast, but they plateau at about 60 to 70%. While in Malaysia, there was this delay in vaccinating their population, still with a difference between high and low, but the total number, like the fraction of the population was higher than, let's say, Cape Verde. So we wanted to understand, are these differences meaningful, and what does it mean in the context of socioeconomic differences? Okay, I will have to, can I go a little over since we are a little bit ahead? Okay, just to make sure, if not, I will rush. So, until 10:10, okay. So, what we did now, in fact, now the triangles are the observed data, and the lines, and the circles that you cannot see. The circles and the triangles are the observed data, and these continuous and dashed lines are fitting of this functional response. So it's a very flexible functional response that has 3 parameters. One is the shape parameter and tells you how sigmoidal it is, whether it's an S shape or a more concave shape. Then you have the week at which half of the vaccination potential is reached, and I will show in a second a plot of that. And then the third one is the potential maximum vaccination of the population. So let's now see what it means in terms of the data. So BM, which is probably the easiest to interpret, is like where, if we continue this kind of purple continuous line, where we'll end up? It will end up here, according to this model. And then the dashed line will have end up here. Similarly, and then what we did was to split this data into 2, based on high and low SES, into a concave dynamics that, again, it has a faster rollout, but it plateaus at a lower level, versus a sigmoidal dynamics that is more similar to the Malaysian dynamics, in which it has a slower rollout, let's say because they were only vaccinating like elder individuals and they wanted to wait and then start to vaccinate the rest of the population, but they were able to reach a higher plateau. So how relevant is this for disease dynamics? So from these 2 curves, we can actually go back. This is kind of aggregated number of individuals vaccinated over time. So we can do a daily number of individuals that are being vaccinated instead of like the cumulative numbers of individuals. And these 2 curves now can relate to these 2. So the concave have an earlier peak and then it slows down. And then the sigmoidal is kind of 2 months later. And then again, the high and low are like the differences between the continuous and the dashed line. I'm not going to talk about details, but we can estimate, like implement a disease transmission model based on this SEIR dynamics that Joe presented earlier on. And therefore, we can, based on this vaccination and the transmission chain, we can estimate the cumulative death of these populations. And what we thought, and we tested 2 scenarios, vaccination starting immediately, which was very unlikely because vaccines were not available right away, versus a scenario where vaccination started 7 months later. And what I thought was very striking about this work is that we compare different scenarios. It's like, what if, okay, we don't have anyone vaccinated? How does that compare to 4 different scenarios? And this is like the scenario kind of approach that Joe was mentioning earlier versus like a forecasting approach. We had 4 different scenarios. One, equity best case, in which now we jump everybody in the low SES to behave like the high SES. Similarly, the disparity worst case is to move the, have equivalent to California. So where the high and the low were the greatest difference. And then we have 2 alternative models. One, disparity average, in which now the averaging high SES, we average the parameters from both high and low SES. And then the equity average, which was a similar scenario. So what we found is that, and then the colors, sorry, I didn't mention that because they are not here in the legend, but the teal is the concave and the purple is the sigmoidal. So moving people in the sigmoidal type of dynamics, in which you have a slower start but then a high reach, like total number of people vaccinated, even if you move from the worst case, California case, to a place where you bump everybody in the low SES to the high SES, your reduction is about 16%. But if you now, even in the presence of the worst case scenario, you start vaccinating everybody earlier on, you have a 27% reduction. And I think this is very important because you can't really do much in terms of equity, right? Like bumping people to behave like a high SES is very challenging, but it is more likely that you start vaccinating people earlier on. So this is a phase diagram. It's a little overwhelming, but I will tell you 2 kind of main take-home messages from this. So if we kind of tested different times, right, in which now this tells me about that middle point. So basically, the lower numbers in the x-axis tells me how fast is the dynamic, being like 30 very slow dynamic to begin with, and being 5 very fast. And then the y-axis is the potential maximum. Whether you reach 100% or you reach 50% has your potential maximum. And what you can see is that moving people from the 30 weeks delay to a 5-week delay, it really improves, the colors are very different here, right? So it really improves your total number of infections averted. But if you move from 50% to 100%, you still have infections averted that are not as high as the number of infections that you will avert if you move to have a faster rollout. So fast initial vaccine rollout has the largest effect on COVID transmission at the population level. Okay, I think I'm good with time. So to summarize, we found with these 2 pieces of work, we found that a strong association between socioeconomic status and both disease outcomes and public health capacity at different stages of transmission, and that timing of initial vaccination rollout affect disease outcomes more substantially than final coverage or the degree of disease disparity, SES disparity. With that, I will thank my lab members. This was work mostly done by Sophie Larsen, a PhD in my group. And we did have a lot of undergrads helping with data collection, especially from the stats department, and my collaborators and some funding. So thank you. And I will have to leave at 11 because of my flight. So maybe I'll take questions now if that's okay. If we have, I think, 5 minutes. Yeah. And I don't know if there are questions in the chat as well. Okay, thank you. Yes.
There it is. I'm curious, I'm thinking about Illinois, like how you accounted for like Champaign-Urbana has a less variability of the SES, but then like in COVID, there'd be less disease transmission compared to like Chicago, where there's a huge range, like there's going to be a huge variability in SES and a lot higher disease transmission. How you accounted for that in both of your models?
That's a great question. Well, in the first one, we didn't really model. I mean, we only used the death to infer the incidence based on population density. So we didn't take into account. And these municipalities in Santiago are relatively small, so they don't have a high variation in terms of SES. For the second part, that's a great question because we did take information at the county level, and Cook County, where Chicago is highly variable, right? So it is true that there we aggregate, like we did an average of the county level SES, and that has a lot of variation that could be very informative, and we did not take into account that because there wasn't data available at a lower resolution. So all the vaccine data was available at the county level. So even though it's highly heterogeneous, we didn't know how the heterogeneity played a role in vaccine uptake. But now in our work that I'm not presenting, we are looking at Illinois and cases of influenza, COVID, and RSV at a zip code level, and hopefully that will give us a little more information about that. Yeah. Yes, Joe.
The quick question. Great talk,
Thank you.
Pamela. Thank you. This is maybe a hard question, but if you were to do these studies again, and you just talked about these data challenges, is there a piece of data or like a spatial scale of data that you think would be most useful for your modeling to
Yes.
extract more information?
That's a great question. Well, I think especially thinking about socioeconomic or race ethnicity, it's tricky because if you get data at the zip code level, then you have issues like being like identifiable data, right? So and the same with mobility. I remember like data for good will not be able to give you very granular data because they were afraid that then you will be able to identify who is moving across the city, right? So I think the more granular data, it's more helpful to understand some of these dynamics, but it's at the expenses of taking a risk of being identifiable. So I don't know, there are statistical techniques in which you could add noise to the data, and therefore instead of saying there are 2 cases, there might be 3 cases, and the same with like death cases that will then prevent that identifiable issue. But I think it's a great question, and I think the more granular the better. Well, until the point that you don't need the individual level information. I think there might be a threshold, but county level for sure, especially in big cities, is not ideal. But I don't know how to deal with that issue. Yeah, that's a great and difficult question. Yes, Ek.
Joe already asked half my question. The other part of it that I wanted to ask was, why did you choose Santiago? Was it specifically because data access was easier there, or there was more available there? Some of the things that we've discovered in our work during COVID was exactly this, is that getting our hands on actual observational data was difficult. So I wondered why. First thing I thought is, well, Santiago, maybe they have different data access rules or mechanisms, and it was easier there. Was that true?
Yeah, I mean, I don't know. They had a GitHub. Okay, I can talk a little bit maybe about the data availability there. So they had a GitHub, and in fact, I'm not showing, but they had like this type of data that I thought was very unique for Santiago. They had the number of positivity over time disaggregated by municipality. And again, because it's a big city, we didn't have this issue because some municipalities have tens of thousands of people. It's a very dense city. It has like 7-8 million people. So But they had number of positivity. They had what we found timeliness was how fast they were reporting the tests back to their users. And I think, again, if you look at all the data combined, we were like, wow, this is a very helpful source to understand particular SES differences. Now, another reason why was because I was helping the government earlier on. And it was very striking to see that cases were very bad in low SES. And because I'm from Santiago, I will pick this municipality is the very low SES and it has so many cases and that motivated. But yeah, I think it was a mix of things that I'm very familiar with the city and also the quality of the data and how fast they were releasing was great. And even now, post-pandemic, the government releases all the hospitalization data for the entire country at the municipality level, aggregated per month. So we are continuing doing studies of influenza, RSV, and COVID in the not so much in the context of SES, but in the context of seasonality. But yeah, the data is there, and the deaths again are very reliable, and they post all the death and with the IC10 codes. So you could study a lot of things, not only infectious diseases. But I think it's a government that is willing to give a lot of data, and then there are questions that might be interesting of that particular setting.
All right, it's my pleasure to introduce a round of speakers from locally here at NAU, starting with Dr. Jeffrey Covington, who's a senior data scientist in my group at NAU and has been leading a really awesome effort to understand the social determinants of health and their effects on COVID transmission across the US. Thank you, Jeff.
Thank you, Joe. Ooh. Yes, so thank you for that introduction. So I want to begin by talking about social determinants of health. Social determinants of health are social factors that affect health outcomes. And there's been a lot of research that social determinants of health are actually quite important. And one of the things I'm going to address today is how important they are in improving models. They're an important source of data. So they're important for addressing health equity, but they can also provide predictive power. You may have heard that the more data you have, the better. And also, at least one of these papers was also mentioned in Pamela's talk. All right, so here are a few social determinants of health and also related health factors. So for example, like the proportion of a population age 25 or over, the smoking rate, the obesity rate, the diabetes rate, these are all important sources of data, but it's a little bit difficult to tell how they relate to, for example, COVID. All right, but you can see that these factors can vary wildly from region to region. There's variation in space. For some of them, there's also variation in time. So social determinants of health, which I will often abbreviate as SDH, are important for health outcomes, but it can be difficult to incorporate them into models. Like for example, it can be difficult to mechanistically understand like how the diabetes rate in a county would affect the COVID incidence. It's important, but it's hard to understand exactly why. And so that's one of the main challenges I want to address in this talk is explore some methods of how you can do that. And so I'm going to do that using a case study on COVID prevalence from 2020 to 2023. And here you can see, for example, urban versus rural counties in the United States. And this is one of the main social determinants that I'm going to focus on. All right, so we got data from, so Johns Hopkins University maintained a big database where they tried to aggregate all the sources of COVID cases from 2020 to 2023. It's a really impressive effort. And so here we're focusing on the contiguous United States. So we have around 3,100 counties in the contiguous United States, and we have over 1,000 days of data. So this is confirmed COVID case data. And we use that confirmed case data to estimate the COVID prevalence over time. So prevalence meaning the number of active cases per 100,000 people. Right, so here we can see the COVID prevalence on a particular day. And we can see that some counties have high prevalence, some counties have a low prevalence. And then on the bottom here, we can see the prevalence over time. And this is the distribution among counties. So the red line is the median prevalence. And we can see some counties have a high prevalence, some counties have a low prevalence. So there's a lot of variation even within the United States. So here we collected social determinant of health data from various sources. And we also determined rural versus urban based on the United States Department of Agriculture's RUCA codes. That's a combination of commuter data, population data, among other things. But this is the classification that we used. And here we plot the median prevalence of rural versus urban counties over time. And you can see that there are differences in timing and in magnitude, right? So here, for example, early on, we saw that rural counties, their prevalence increased first and then urban counties, but later on, there are examples where urban counties went first and then rural counties followed. So there can be a lot of differences in the dynamics of COVID between these areas. All right, so let's talk about how we can actually model this data. So like I mentioned before, it's difficult to mechanistically model the effects of social determinants of health. So what we're going to use is a statistical model. So unlike the models that Joe was talking about earlier, which are based on known disease dynamics, this is a purely statistical model, which has pros and cons. One of the pros is you can more easily include social determinants, in this case through a linear regression. But one of the cons is that we're basically constrained to making correlation or drawing correlational conclusions, right? So correlation does not equal causation, right? There can be confounding factors. Every kind of model struggles with this, but I think with statistical models, you have a little bit less to work on for establishing causality. That being said, it can be a great starting point for asking those questions. So this is the only equation that's going to be in this slide. So this is the structure of the model. So the COVID prevalence is going to be the regression model. This is the SDH, plus the spatiotemporal effect. So counties are related both spatially, and then also the prevalence within a county changes over time. So just to mention some jargon, the spatiotemporal effect is a combination of a Gaussian process in the spatial direction and an autoregressive process in the temporal regression or in the temporal component. I think I said regression one too many times there, I'm sorry. And then the noise component, this is statistical noise. I did want to take a brief aside just to talk about one of the interesting computational techniques we used. So Joe mentioned earlier that there's the mathematical model you want to use, and then you have to translate it to computer code. In this case, the model we wanted to use in the spatial direction was too computationally expensive. And so one of the techniques we use to reduce that computational cost while maintaining accuracy is called low-rank kriging. But essentially, instead of considering all 3,000 counties for your spatial effect, we used 200 knots that are roughly evenly distributed around the geography. And in this way, this greatly reduces the computational cost because you'll be running this model thousands of times in order to fit it while maintaining accuracy. And this is just an illustrative example of how that actually looks in the model. All right, so here are some of the social determinants of health that we used. So rural versus urban is the main one. We talked about some of these earlier, but we're also including interaction effects. So given that you're in an urban or rural county, some of these may have additional effects beyond just a normal linear regression. So we included those interaction terms as well. I also want to emphasize that there are many, many covariates that you could add. Right? These are just the ones that we happen to do. We wanted to keep it to a small set, and these are all were all found to be significant in the model. All right, so one of the main things I'm interested in is the predictive power of the model. So in order to evaluate how well it can predict data it hasn't seen, we fit the model on only 75% of the counties in the data set. So we artificially removed 25% of counties. We fit the model on the remaining 75%. And those 25% that we excluded, we're going to compare the true data to the predictions from the model in order to evaluate its skill. And further, in order to assess the contribution of the social determinants of health data, we did versions where we excluded the social determinants of health, and we did versions where we included the social determinants of health to see how well they can improve the predictions. All right, so here are some examples of the model predictions. So these are 4 counties in the United States that I chose arbitrarily. The 2 on the left are rural counties, and the 2 on the right are urban counties. And so what you can see here is the red line is the true data, and the blue line and the blue error bars are the predictions from the model. So the 2 rural counties on the left, we have Coconino County, Arizona, and Lunenburg County, Virginia. And we can see it, the true data is contained in the error bars, and it roughly follows the trends pretty well. But then on the right, we have 2 urban counties. So New York, that's Manhattan, and Cook County, Illinois, that is Chicago. Or it's more than just Chicago, but overall, it did pretty well. I do want to mention one thing. I picked Cook County, Illinois specifically because I noticed that it seems to have a bit of a bias. The model actually overestimated the true data. So I picked this one out just because I wanted to say the predictions can be good, but there are also examples where the predictions don't do as well. All right, so those were just a few examples. How did it do overall? So here, among all the counties that we were predicting, we can compare the model with just the linear regression, so only including social determinants of health, but not including the spatiotemporal component. So if you just did a linear regression, the model actually doesn't do that well at prediction. This dashed black line is a baseline. This is essentially a null model. So we can see if you include the spatiotemporal effect, it greatly increases the predictive power. And then if you include SDH on top of that, it increases it further. The scale is a little weird, but this is a 7% decrease in the error, which is actually quite large. And this is for this particular metric, root mean squared error. Here we have another metric called log likelihood, where the decrease in error is even larger. And log likelihood includes not just the prediction, but also the uncertainty as well, which is an important component of the model. All right, and one other interesting conclusion is we want to compare how well does it improve the prediction for urban counties versus rural counties. So among urban counties, including the social determinants of health, it improves the predictions, but only by a little bit. But among rural counties, including the social determinants of health data, increases the predictive power significantly more, which I think is an interesting conclusion. So one caveat, a lot of the regressions here were did include the interaction terms with the rural versus urban. Oh, sorry, was there? Oh yeah, sounds good. One last thing I wanted to mention. So Pamela mentioned data availability issues. So oftentimes our rural counties will have some data availability issues that can be a combination of variation in data collection practices, availability of resources, and also different policy things. So here, for example, this is Box Elder, Utah, which did not have any reported data in this particular data set. And so we can use our model to say, hey, this is what we actually think the true prevalence was over time. All right, so I'll wrap it up shortly, but just a few quick conclusions. Or First, a discussion on the differences between urban and rural counties. One, differences in social determinants of health. We only include a few covariates in this model, but there are many, many more social determinants we could include. Data reporting and availability. I talked about that in the last slide. And also small population sizes. So even though we controlled for population, small populations still tend to have a higher variability in whichever statistic you're collecting. So that's another difference that there can be. So just a few conclusions. Incorporating social determinants can improve the predictive power of models. They're a very important source of data. And so it's important to explore methods on how to incorporate them. Another thing was modeling the spatial temporal effect was key to unlocking the value of the social determinants in the model. And that this model can serve as a framework for further studies. And I have some ideas for future research that we're actively working on, but I may save those for another time. And so these are our funding sources. And thank you. All right, we're slightly over time, so maybe we'll, yeah, I want to do lunch on time too. Maybe some quick questions. Yeah. Oh, so this was, this actually was not forecasting. I'm sorry, I didn't make that clear. Yeah, it was not forecasting. Right, so the question was, can I clarify the predictions? This was not forecasting data forward in time. What it was essentially predicting the incidence in one county based on the data from the surrounding counties.
I see.
Based on the spatial correlation.
For the time period.
Yes, for the same time period.
But how is the time dynamics done? Like how do you?
That was an autoregressive process.
Sorry, we're going to hold the questions. We have a special like question and answer session. So write down your questions and we'll get to those. I just want to make sure that we get all the speakers in on time. And thanks so much, Jeff. I'm happy to introduce our next speaker, who's Dr. Ye Chen from Northern Arizona University. She's an associate professor in the Department of Mathematics and Statistics and is a close collaborator of ours.
Right. Thank you, Joe, for the introduction, and thank you for the invitation. It's my pleasure to give a talk on what we have been doing for the flu forecasting and modeling. So I am an associate professor in the Department of Mathematics and Statistics in Northern Arizona University. And I really want to put everyone's name in the first slide so that I do be very busy. But these are the collaborators who have been helping in putting up the different versions of flu forecasting models and testing them, and without any of them, this would be impossible. So, so the flu forecast activities from Northern Arizona and Los Alamos started in the end of 2021. Which when was, if you remember, that was when the surge of Omicron has already started. And then at the time, I would just finish updating my COVID model for including the Omicron variants. And my two collaborators in Los Alamos asked me if I would be interested in participating in forecasting the flu for CDC. So I said that would be wonderful if we can test our theory and the model for different disease. So but at the time, that was right after Christmas of 2021, and the flu forecast activity has already started at the time. So we were kind of very putting this quickly, and three of us was just working more than 10 hours a day for 7 days. And in the morning, we got into the Zoom, and then because there was the during the pandemic. So we were just, each of us were coding something differently and testing something differently. And eventually, in the end of the 7 days, the model was working nicely, and then we submitted our first result. That was already after the new year of 2022. And that was the first version of the flu forecasting model. And then it didn't work well in the first time. So in the 2022 to 2023 season, we changed our model and has been using the model up to date. So currently, Joe, Egg, Jay Cho, Jeff, and all the students in the NAU list, and then also the people in Los Alamos, and I got collaborators in Louisville and Cornell are helping to working on creating the third generation of our flu forecasting model. So then I want to talk about what is why do we want to do the flu forecast? So the first, the flu is an annual burden in the U.S. which causes 9 to 41 millions of people infected, and then there's about 140 1,000 people to 910,000 people were hospitalized, and also cost 12,000 to 52,000 deaths every year. It's season. Usually, when people talk about flu, it's a flu season that we're talking about, which usually starting at the fall every year and ends in the spring the next year. And why forecasting help? Because that will help us to guide the early warning and preventions, and optimize resource location, inform decision making, reduce economic and health impact, and enhance public awareness and future preparedness. But it's not that simple. There are also challenges when we're doing the full forecasting, because there's seasonal variations. The timing and peak and intensity of the peak changes every year, and that could be caused by the multiple circulating strains, and because the flu strains will change every year. And then there's also delay and noise in the surveillance data. And we also observe that the weather and human behavior, like what we learn is that the social determinants of health and the movement will also have impact on the flu. And this is the latest the flu forecasting. If you look at CDC's website, that's the national forecast for US at the national level. So you can see that the flu currently the activity is calming down. But you also might think about that. Well, it looks like this is very simple, right? This is a straight line. Can human being do a good job as well? I will answer the question 2 slides after. So first, what is the flu site challenge? It's an annual forecasting challenge hosted by CDC since 2013, and this activity brings together academic team, government labs, and private groups. So if any one of you would be interested in submitting results, you can just feel free and just sign out a team and let the people who organize the activity knows, and then you can just submit your result. So if you think that as a human being, you would do better job than any of the forecasting models, and you can just look at the table and look at the numbers and submit your results. They will take the result. Okay, that would be a very, very interesting experiment, actually. And then the aim is to improve the real-time forecast of seasonal influenza in the US. And the goal of the challenge is to evaluate the accuracy and reliability of the flu forecast and improve tools for public health preparedness, encourage innovation in epidemiological modeling. So what are we submitting for each team? So it's a subset of these things every year, and it varies every year. So currently, we're submitting the onset week. So there's a cutoff when the flu season begins. Like if you have you meet certain level of flu activity, then you need to, that's called the onset week. So we need to forecast that. And what is the peak? That's when the flu activity will be highest, and the peak intensity is how high the activity will be. So currently we're forecasting at the peak how many people will be hospitalized. And we're also forecasting 1 to 4 weeks ahead hospitalization case counts currently. So like 1 week ahead, at what is the number of Arizona of the hospitalization case numbers in Arizona and in other other states as well. So the forecast results will cover state level and national level. And this is a website all right, so I'm going to see. All right, so I actually put a link here because I was going to show you what is it in this link that you can actually track the forecasting results, but it was not running correctly when I checked in this morning. Perhaps they are updating the results today. So in these slides, I will answer several questions. The first is, what are the major models being used for real-time forecast? I just want to emphasize this is real-time forecast. So there are some other additional models that are not covered because they're not often used for real-time forecast. Maybe it's because they're difficult to run and it takes a long time to converge. So these are the major models. Mechanistic models like the compartmental models is sometimes it's called like mathematical models, and statistical models like a time series model, machine learning models for inference, and like deep neural networks is also used. Phylogenetic models which check the phylogenetic change of the flu mutations, and digital surveillance model are sometimes also used to check like the Facebook activities or Google search activities and integrate that with the models. And most importantly, I want to say something about this ensemble models. The ensemble models is actually average across all the forecast results. And it's actually the second most accurate model measured by a score, an accuracy score between 2021 to 2022 season, and it's the fifth most accurate score, accurate forecast in 2022 to 2023 season, and so if you look at this figure, it's actually listing all the teams participating in the forecasting activity at the season, the last flu season from 2022 to 2023, and there are some patterns when people the team on these team names. So the first is the name of the team, and the second part has the model. So you can kind of get an idea of like this is CMU team and they use time series model. And I just want to bring your attention to the last one and answer the question I left 2 slides before. What about the human judgment? This is the Lehigh University's computational and certainty lab experiments. They just recruited some human beings and then using the human judgment to make the forecast. And this is a ranking of the accuracy score. As you can see, that human judgment didn't do well. So just wanted to answer the question that I left 2 slides before. And the ensemble results is actually very good, very surprised. And you might wonder why. Why is the ensemble results so good? And I like to show this slide, this figure. Although this is not the latest result, because the team was, our team, Los Alamos NAU team, was actually ranked top in the top 3 in this figure. Because later on, the ranking dropped. So then. Why is it the ensemble result is always doing so well? So this is a figure that is being is summarizing the flu side results from 2021 to 2023. So this first figure here is the 2021 to 2022 result, and the black dots are showing in these figures are the real hospitalization result at the national level. So the blue ones are the ensemble results from the forecast from all the teams. So you can see that at the beginning of 2021 season, it's kind of off on the real data, right? But when it gets to close to the peak, the forecasting result is getting closer, and then it gets off to the actual data, far away from the actual data again at the end of the season. But that's not the case in the 2022 to 2023 season. It was actually closer, maybe not so close, but it was most of the models were not able to forecast the peak, and then it's still off when it gets close to the end until it really calms down. Then everyone is forecasting zeros perfectly. So that's the 2022 to 2023 results. And if you break down this result to each team, that's one slideshot of the forecasting results. So you can see that the forecasting were done in the before the December, and it's forecasting 4 weeks ahead. You get 1 week, 2 weeks, 3 weeks, and 4 weeks in this. So each team has 4 dots, and you can see that what was happening in here is that many models were making mistakes, and the ensemble model is taking the average of those mistakes. And at the peak, for the 2023 season, so not every model was making mistakes. So some of the models still have the coverage, but most model was making the mistake. So the ensemble model is like taking the average of all the mistakes. So, so as you can see, that individual models, I put a summary here, that it's often vary greatly in their performance within and across seasons. So some of these models would do well when the case number started to rise, and they are more sensitive to the change, and some models are doing better when they are forecasting the peak and peak intensity. So ensemble model may have decreased performance during periods of rapid change, and when some individual models may have higher accuracy during some periods. So it's taking the ensemble of all these models, so it's reducing the likelihood of failing. That's the major takeout of this paper. And when it gets to the end, most of these teams are forecasting something close to 0, so that it's actually more accurate in the end. So that's the forecast activity. And here in these slides, I want to give you an introduction of the model that we've been using. Is a compartmental model where we split people into susceptible, infected, and recovered population, and we use mathematical model to move people between these 3 compartments. And here, a major parameter that on how fast you're moving people from susceptible to infected population is called a beta. Sorry, 5 minutes. And then you just in the first and the second version of our model, and this is also the model that we're using currently, is that we're modeling this flow from susceptible to infected population as a step function and then we use a machine learning algorithm to detect where, when, and how much the transmission, which is this beta parameter, is changed over time. And the current results for Arizona is this. So we're kind of forecasting close to this flu site ensemble result. And that's also the result that we just submitted to CDC on Wednesday. And so this is so the model here is actually taking quite a bit of time to run because finding the change time points and the flu transmission rate is actually difficult to find out. And Usually it takes several hours to get the computations done, and we normally do that in the clusters, computing clusters. And but however, you may think this is still possible, but however, the flu forecast is only, if you want to use the latest data for the flu forecast, the data is released every Wednesday morning between 9 to 11, and the submission is still around 9 o'clock in the evening. So it's really a very intensive activity. So you need to make sure that everything is running perfectly, and so you can submit some reasonable result by the end of the day. If there's something wrong, then sorry that you either skip the submission or you just submit something wrong and let the, because you don't know, maybe it's wrong. You don't know it's wrong. You never know, right? It's forecasting. So we're thinking, instead of having that, the model is taking so much time to run, and at the end of the day, we have almost no time. If there's a mistake happen, then we think that there's a computational mistake. There's almost no time to correct the model. So therefore, we're thinking thinking a more sensitive approach to detect the changes in this flu dynamics, and this is our current approach. Is instead of using a step function, we just assuming that the transmission change over daily, and we use a trend detection algorithm to detect the changes, and that will be the third version of our model, and then we but we're still in the testing stage, and that's the major framework of our third version of flu forecast model that hopefully we can put it to run for the next flu season. And then this model is integration of compartmental models here, and some machine learning algorithms, and some time series models, and we also do the forecast calibration in the end. So hopefully this will improve the forecast activity. And so I just want to mention that it's when I was looking at this result, it doesn't look good, meaning that there is room. That's why as scientists we want to work on that to improve the forecast accuracy, right? Because the model is not doing well, so we want to improve it. So I think that would be the last slide of the talk, and thank you.
Thanks, Dr. Chen. It's now my pleasure to introduce Dr. Coyote Oshinubi, who will be talking to us again about forecasting, but this time with a very different disease system, West Nile virus. And Dr. Oshinubi is a postdoctoral researcher in my lab at NAU, and we're very lucky to have him.
Thank you, Joe, for the introduction. Firstly, I want to appreciate collaborators on this project. Crystal is at the hall. Thank you for always asking our call when we call out for data. And the data is from Maricopa County Vector Control Division. Irene is not here today. Hak here, and Joe, who is the PI on the project. Yeah, mosquito-borne disease is a burden in Maricopa County and in Arizona generally, because according to the CDC, Maricopa County is one of the top counties with West Nile virus disease burden. And we have this species, which is very difficult to pronounce. So we has before coming to this talk, is Quercus culex mosquitoes, which Arizona has different kind of species, but this species is very important, and this is the species we are really working with. The data we are using for this modeling, and because this species, it's is host of avian malaria, SLEV, and also West Nile virus, which is the major point here. And in total, we have about more than 3,000 human cases, from 1999 to 2023, and and this disease, West Nile virus, can lead to severe neuroinvasive disease, including meningitis. And then this is one of the data we got, on the CDC website. And what is West Nile virus? I know you'll be asked, you're curious about what is going on. What is this virus? And this virus has a lot of components in it. We have the mosquitoes, which I talked about. The female mosquito, we bite bird, can bite human, also can bite horses. We are not considering horses. Today we will just be considering mosquitoes, bird, and also human in our modeling framework. So that is what we are going to be focusing on. But in Germany, some papers, from German researchers, they have data on horses. They normally consider that. So this is the way this disease is being transmitted from bird to mosquitoes, from mosquito to bird, and then humans and horse are the dead end host. They can't infect mosquitoes or infect bird, so they are the dead end host. So West Nile, was able to spread, rapidly in the United States, primarily because often affects highly mobile, migrating, birds. And the animation is not working. Okay. This figure is a kind of a projected climate change scenario from 2019 to about 2080, and then the red color shows the number of transmission of Aedes mosquito across regions. So those places that are red, it means that there will be more transmission of mosquitoes in those places. So climate change will likely alter large-scale distribution patterns of mosquito population, and disease. And I want to delve a bit into, the data we have. So there are trap locations. The red dot is represent the trap location. So Crystal team, they set traps across Arizona, and every week, data are collected, and these mosquitoes are tested, and also they are separated by male and female because it's the female that bites. So we are more interested in the female data, and then they also identify the kind of pathogen. So we have different pathogens that they carry, but we separate this pathogen, West Nile virus, because there's also data for SLEV in that data set. So they identify the kind of pathogen they carry. So for mosquitoes, these traps are set across county. And this is the 3 data set we'll be dealing with. The human data comes from the hospital, and we have the abundance, so from the traps, and also the mosquito prevalence data set. And also, so you'll be seeing this 3 figures because of this is what 3 data we'll be dealing with in this modeling framework. And so we have very large data set across, we have up to 2024, which you are still going to see, but just to show you a few, that from 2006 to 2017 data that is presented here, there's a kind of correlation between the infected human and the mosquito prevalence. But you'll see some kind of delay, and when you compare 2006 here, you will see that there's a kind of shift, a bit of shift between the mosquito prevalence, those are the infected mosquitoes, and the human case. But you see that there's a pattern, there's a kind of correlation. So so infectious mosquito per 1,000, which is the mosquito prevalence, correlates with human cases. And the reason why we are showing you this is that we believe that if we can predict or forecast this data of mosquito prevalence, of course we should be able to predict or forecast the human cases. So our vision for this work is, number 1, collect this data set. We want to use climate data set. Climate data set here that we are going to be using is temperature and precipitation, which Joe talked about earlier, and also the mosquito data, and also the West Nile virus prevalence data. And then we will build a model. And I know some of you will be saying, oh, hospital is there. How are we going to account for hospital, for mosquitoes, bird, and all of that now? I'm just showing you a general framework, for the mosquito, we are just looking at susceptible infected, but for human, we can extend that. So for bird also, we are looking at susceptible, but you are going to get a clearer picture later in the talk. So we are not considering hospitalized for bird or mosquitoes. And, we are going to, have a forecasting framework. So whenever I use the word fitting or prediction, I'm just talking about this part, what is going on in this part. But when I use the word forecast, I'm talking about what is going on in this part of the vision for this work. So, but also there is temperature and precipitation here, but I'm just highlighting that, okay, in the forecast, we're also using temperature and precipitation. And then the last vision of this work is to, to support decisions, intervention, public awareness, how, mosquito can cause, diseases and make people sick. And our problem statement is that you can see the complexity in this modeling framework, temperature, data from human, bird, mosquitoes, and all of that. There's difficulties in explaining mosquito abundance. Also, we want to develop a better scientific fitting technique to solve this problem. And we want to forecast the mosquito population, we want to forecast the Western virus prevalence. Also, we want to, be able to, predict model parameters and also, have this input of temperature and precipitation. So that is what we want to do. So this is our model, our big model. So you can see that the mosquitoes model this way, this is the bird, and this is the human. So the human, we have the exposed, compartment, and then they are infected, and then they are hospitalized, and then some recovered and some died. This was informed by the kind of data set we have, and also for the mosquito. But I just want to highlight the first part of the equation. I don't want to bore you with a lot of math. The equation is large, so, but it might not be interesting. But this is very interesting part of the work because the mosquito population, that's the susceptible mosquito, has a quadratic effect of temperature and also an effect of precipitation on the population growth, which we modeled. And this precipitation, we try to do a daily accumulated, 30-day accumulated, and then we scaled it. We scaled it by 50 just to scale this data set. And also we have the disease transmission, which is the bite and then the transmission rates, and this transmission is between bird and mosquitoes. You can see that it's just B and M we have here. So there's also a transmission between mosquitoes and human, but that's another equation. And then we have this parameter that is time varying. All that parameter here. So when I said static, time varying parameter, this is time varying, and then this is what we mean by static parameter. This alpha statics. Then we fix the death rate. We fix that, and yeah. So this is the first part of the equation, the complex equation, and our statistical framework and our forecasting strategy, is to fit our data for a certain period of time. Just 7 weeks is just an assumption, but what we did is a 52 weeks. 1 year we fixed for 1 year, and then we slide 2 weeks. We forecast 2 weeks forward with temperature and precipitation data. So we use a sample comma filter method for that, and then we also grab the precipitation and temperature data for 2 weeks. We go on the OD model that I showed earlier, and then we repeat this test for 52 weeks. That is, if you are forecasting 2024, we fit the data for 2013, and then we do a 2 weeks for 52 weeks in 2014, which result I'm going to show. So fitting result, or what we call prediction result. Yeah, I know the question you'll be asking that why are we picking some years? The reason why we picked 2014 is a monsoon year, so that was why we picked 2014. So I'll tell you the reason why we are picking some of these. So we fit our model to these 3 data set that we have, and you can see that our model was able to, we're successful. We successfully predict mosquito population and Western virus prevalence for 14. So our new method, improves model fits to data. And then the reason why we picked 2021 is because the data set we have now for all these 3 data sets stops at 2021. So we just want to show the 3 fitting for the current data set. So this is it's not a very good fit, but yeah, so some of these places, they are good fit, just to highlight where is good, this is not really great, and this you can say it's overfit, because everything just match up, it match up, so so our new method also improves, more model fit for a kind of a recent data. And, like Joe said in his talk, perhaps we need to, like what Joe said, he said, sometimes, data change over time, and then you need to kind of tune, your modeling framework. So we think that perhaps we need to still do some more work. And this discussion is, is ongoing, to improve, this not too good projection. And yeah, and also, we have for 2014, just last year, and then you can see that we don't have the human data. Like I said, we have these 2 data set, and our model, was able to, to capture the dynamics of the total population and the prevalence. So our fitting techniques has remained robust and effective over a 10-year period from 2014 to 2024. And then I want to talk about forecasting result, this 2 weeks forecast that we did, and we did 2 kind of scenario, 1 week ahead forecast and then 2 week ahead forecast. And you can see our forecasting result. The red line is the real data, and then the blue dots is the forecast, and then the bar you are seeing is the confidence interval or the certainty in the forecast. So yeah, at this point in the time series, we have very good kind of results, and then here you can see this is far. So when it is far from, or the line does not match up, this is very far from the real data. And what happens here is that to forecast this 2 point, let me say, to forecast this point, this is 1 week. That means we fit the model up to this point. So we feel that our forecasting framework, has been able to to forecast pretty well across the time series. And then we have the 2 weeks ahead forecast, where the black is the black dot is the forecast, the red is still the real data, and then the yellow bars are the lines. So here you can see that the forecast is not too too great, but at this point the forecast is good. So our forecasting strategy can capture mosquito population at different seasons in the time frame. So what are the major takeaways from this modeling framework? Our modeling and forecasting frameworks, successfully capture seasonal variation in mosquito population, prevalence throughout the decade-long data, and we have successfully used this fitting framework, ensemble common filter, to fit mosquitoes' abundance, Western virus, and incorporate the effects of climate. And also, despite these changes in environmental conditions, data quality, underlying dynamics, for over this decade, our method constantly capture key trends and variation in mosquito abundance. Also, we strongly believe that, our approach will be useful for predicting, human risks of mosquito-borne disease. And this long-time consistency allows the reliability and adaptability of our approach, making it a valuable, tool for forecast and also for decision making. And I don't really want to go over all of this because of time. And what we are thinking for the future is that if we incorporate temperature and precipitation, we have incorporated temperature and precipitation, but we didn't incorporate the uncertainty in this temperature and precipitation. So we feel that that should be done. And then we are using historical temperature and precipitation data. So we need to use, like using, more recent precipitation and temperature data, and also to evaluate our forecast on-demand, mosquito data and for different mosquito species. I didn't show the forecast of 2024, using 2023 and 2024 data because we are still trying to fine tune that, and also expand our forecasting framework by generating forecasts of disease count and West Nile virus prevalence. We have not done that. Our forecasting is only for the mosquitoes abundance. So we are hoping to be able to forecast, disease count and the West Nile virus prevalence. And we want to acknowledge our funding agency, and yeah, any questions? Thank you.
Thank you, Coyote. So now we have the panel discussion, but I was thinking maybe we'd do a 5-minute break just to grab some coffee or water, and we'll do our panel discussion. So think of any questions you might have for our panelists, and we'll come back in 5 minutes. And then after the panel will be lunch. Thank you. Okay, I think we're going to start our question and answer session. So if we could have the speakers, Dr. Chen, Dr. Oshinobi, and Dr. Covington up at the front in these chairs on a podium. All right, any questions from the audience? And make sure to push your button. Yeah.
I have a question for the West Nile team. I actually have 2 questions, and they're kind of contradictory, but it is what it is. It's about the climate data. I noticed like the traps are in a relatively small geographic area, and the variability of like in Maricopa County, the variability of that climate, like geographically, might not be that variable. So do you think that could, if you expanded your trap surveillance, would that improve your model? And the second question is kind of contradictory to that, because if you spend any time in Arizona, you know that like if you're in Mesa, you could get a bunch of rain, but in Glendale, you didn't get any. And the resolution of the climate database might not be where the traps are. So like having like on trap weather data, would that improve the model at all?
Thank you for that question. There's one work we did. We tried, we have the data at the zip code level. So we clustered zip code as the trap data based on a precipitation, similarities in precipitation. So, and then we did a prediction on that. So you are right. If you plot, we have a plot for the temperature. Virtually all these zip code were lying on each other. But for the precipitation, there is a bit of a small variability from across the ZCT. So, and for this, we are aggregating those data. We are taking the whole data of Maricopa County, and we are using Prism, and is the one by 1 kilometer, if I recall correctly, to grab the data. And another thing we tried was to get a data from a station, weather station data. We also got that to see if it is a bit different from Prism, and yeah, there was not much difference. So yeah, you are correct. This climate data are not, there's not much different, but we have done that kind of fitting framework that we clustered traps based on similarities and then the result was not bad. It was good. So there's not much. I don't think even if you move the traps, that's my personal opinion, but maybe Crystal or Joe can add to that. I don't think that will change a whole lot of things, because we have tried to to do this analysis. And I think, is that the first, or maybe I think I've put it. Yeah, I think I've might.
Thanks, Coyote. Any other questions?
I actually have questions to all the speakers, but because one of the previous audience asked to the KOD, so let me start you. So I have a question. The question I have is then, so when you look at one of the component of model, I see you use the temperature data to improve the forecast of the virus data. I think that's going to be, I think the equation you put there is good approaches, I think. So to the temperature of the week, and then minus temperature, minimum temperature, and then multiply that by maximum temperature minus temperature of the week, something like that. So I think that's kind of really good idea, I think. But also one concern I have is that, so when you forecast 1 week ahead or 2 weeks ahead virus data, but you probably also, do you need the temperature forecasting as well? So if that's the case, then if we use that component like quadratic component, temperature component, then if you forecast a bit inaccurately in the forecast, that inaccuracy in the the temperature forecasting may also affect, probably more serious than we expected in the virus forecasting. So I just want to hear your thought about that one. And then do I need to keep to asking another speaker?
I think we'll do one at a time for
One
you.
at a time.
So I think to summarize, like, how do you think your results are sensitive to the fact that we didn't forecast temperature ahead, right? We just used known temperature.
Yeah. I don't know how to, yeah, but I think, we have, some, if you look at that equation, we have some parameters, that are also influencing that equation. They are static parameters across the county. They are not time varying. So, yeah, I think because for now we are just using historic cold data. There's possibility that when we incorporate, the forecast of temperature and precipitation, and perhaps, we're also thinking of adding the uncertainty in this forecast. Perhaps that will help us a bit, to have, good result. And in my opinion, at least from what we have now, I don't think maybe that will make our forecast to badly behave, if we'll incorporate, this mechanism into the forecasting framework.
Okay.
Maybe we'll come back to you for your next questions, if that's okay. Crystal.
Thanks. I have a question for you, Coyote, but I'm going to pop over to Dr. Chen first. I was just wondering, for the flu forecasting data that you're allowed to use, can you, now that they have the National Wastewater Surveillance System, are you able to use flu data from wastewater testing also into the flu forecasting?
Yes, the answer is yes. You can use any data you can get. Actually, in the season 2023 to 2024, the winning team was CMU, and they collaborated with a lab who has been collecting the people's sample, and they did a bunch of samplings, and also they keep track on how many people are infected. So they won the competition for that season because they have more data. And the model that the team currently using is only the surveillance data, no other things. So that's why we're thinking for the third version of our model, we should incorporate weather data, movement data, social determinant of health to improve the forecast accuracy. Yeah, thank you. Did I answer your question?
Yep, thank you.
Yeah, I think we should collaborate on how we could, especially if the CDC wants us to predict the onset week, we could use like surveillance from wastewater systems for that. I think that's a great idea. Yeah.
When measuring social determinants, do use of indexes like area deprivation index or social deprivation index, do those tend to help your model or they tend to blur your model, or do you know?
Yeah, so currently the only index that we tested was an index of community health produced by the University of Wisconsin-Madison. And that one did further improve the effectiveness of the model. Of course, it's kind of tricky because you can get redundancy between data sources, right? If an index is a combination of other covariates that are already included in the model, that can cause some identifiability issues. But certainly, I think you can basically incorporate as much data as you want. Of course, you can run into computational issues, but ideally you would.
I have a quick follow-up to that is I think like indices can sometimes, they'll certainly help with prediction of data, but in terms of explanatory ability, like can I verbally explain why this is important? An index is sometimes difficult, right? Because like some of these indices have like 10 variables that are used to calculate them. So they're very helpful, but can also obscure like reasons behind their influence.
I have some question to the chef. So there are two questions. So one is, you are predicting, I forgot this variable name. Is the response your daily cases, right? So response variable is daily cases, is that right? Estimate the prevalence. Is that daily?
So it was the number of active cases per 100,000 people. And so that also included assumptions for how long cases last. But the fundamental data was the cumulative total cases.
Per day?
Yes.
Okay. Then it feels to me that the SDH, many of those SDH variables are not daily data.
Yes. So in this case, for this particular experiment, all the SDH were kept constant throughout the duration. That assumption is more valid for some social determinants than others. But yeah, certainly if you have a time-dependent social determinant data, you can incorporate that as well.
I see. So when you have the regression model, so you include the daily prevalence as a response variable. Yes. And then those kind of SDH variable into your covariate, but those covariates are all the constant?
Yes. So there's a constant regression component. It varies across space because the counties have different, but the social determinants are kept constant. You can add other regressors elsewhere, like for example, in the spatiotemporal model, you can add, for example, autoregressive coefficients that depend on the social determinants as well. Okay. But in this case, the spatiotemporal component was just in the residuals. But there are many different configurations one could use.
And another question I have is then you mentioned about some differences between rural and urban areas. And do you have some comment what caused that difference?
Yeah, so the original idea was maybe the difference is explained entirely by all the different social determinants that we include in the model. We did find that there are additional effects, both in the interaction terms and in unaccounted for effects for the urban versus rural indicator. It's very interesting. And of course, there are a few statistical differences like data reporting and like higher variance. Yeah, I don't have a question or I don't have an answer, but it's a very interesting question.
Thanks, Jeff. Getting in deep there in the details. I have a question for Dr. Chen, and then I'll get to you, Jake. I'm curious with so the CDC releases data at like 9 a.m. or whatever, and you need to produce a result by 9 p.m. Do you think that's a purposeful aspect of the forecasting framework? Like they want to make sure that your models are efficient, or is that like an issue with data reporting?
Right, thank you for the question. So it's actually you have two options. If you want to submit the forecast result on Wednesday using the latest data, then you will have very little time window. But you don't have to do that. So you can just use what was submitted previous week, and then you just use that data to forecast. Then that will allow your model to run for additional time. And some of this model, like EPI might require a little bit more time to run. Then you could just use what was posted like previous week, and then run based on that model to run whatever you have for the forecast. Then you will forecasting your forecasting horizon will be 2 week and 3 week and 4 weeks ahead. So that will also help.
Thank you. I saw Jake.
Push. I have a question for the gentleman with the West Nile modeling. Is there a reason why you didn't include Culex tarsalis numbers in with the numbers for quinks as a input for the model? And I know down in Maricopa County, just like water features and things like that are also contribute to like mosquito habitat. And is there like a way, maybe like with population density or changes in population density, that like you could add that as a parameter, or if it would even be worth adding as a parameter?
Okay, thank you for that question. There is, I did show that work. There's one work we did. We have all this trap data, and then we discovered that there are about 6 traps that has a lot of high abundance. So, and if you look at the location of those traps, they were around irrigation, the Salt River, and some other places like that. So we try to pull out this trap data, and then we did a fitting routine separately for this 2 set of data, just to separate them, and then because they were adding a lot of spikes into the data that we have. So that's one thing we did, concerning some of these locations, data that have a lot of mosquito population. And yeah, we didn't add other species because majorly this Q whatever this long pronunciation is very important, like I said at the beginning of the talk, because it carries these different diseases. And of course, when we consulted with Crystal in one of our meetings, she said we should try and look at other species. So, and that was why I said one of the work we are going to do is to look at other species and try to put it in our modeling framework. So we are thinking about that also, to see perhaps we'll get. And when it comes to, at some point we were thinking about, apart from precipitation and temperature, we should add a variable that account for standing waters, because where there are standing waters, you have a lot of mosquito population, but we've not been able to do that. So these are some of the things we are looking at in terms of future work. And yeah, that's a wonderful suggestion. Thank you.
Crystal.
I would just add into that a little bit. So approximately 70 to 80% of all mosquito pools that are positive in Maricopa County each year are the Culex quinks, which quinks is a much better way to say that super long name that's really hard to say. And tarsalis account for a smaller proportion, but they're still probably really important for the transmission cycle. But Dr. Oshinobi, what I was thinking during your talk, it looks like 2014 was pretty solid for the model, but 2021 is where you saw that sort of big deviation from the observed versus modeled number of West Nile virus positive mosquito pools. And I wonder if that's because, so we've noticed it too. We think that there was a saturation of the mosquito pools because there's 50 mosquitoes put into one pool. And on a normal year, when you just have you know, a standard and average case of West Nile virus positive mosquitoes floating around, you might expect 1 or 2 positives that are going to be collected in one trap and then tested. But in 2021, we've noticed too with our effective population size estimates that it just like skyrockets versus the number of positive mosquito pools. And I think that there's a saturation issue on these really, really big years. So I think that your model probably got it because the saturation prevented the mosquito abundance from going any higher. I wanted to say that.
Yeah, and I think that's one of the anomalies Joe talked about. You know, we just have this sudden huge spike. So, yeah, but yeah, we are thinking of fine tuning the model. Perhaps we'll still have further discussion and see how we can make that result better.
Are there any questions in the chat, Cindy? No. Okay.
So my experiences with weather forecasting, I can pretty much trust it. I look at my phone and I can guess what it's going to be. Is this compared to weather forecasting? Where are these models for these infectious diseases? Like pretty darn, yeah, it's like forecast the weather, or is it like, we don't know whether to take a coat or not?
I'll let Dr. Chen answer that first.
That's a difficult question. So just for my own model, I would just say that I would trust it more toward the end of the season, when the model knows more information, then the model can forecast more accurately. But for some other models, like statistical models, which is based on time series, they are more sensitive to the changes at the very beginning of the season. So they may not need so much information to forecast, and those models and sometimes will produce more accurate results at the beginning and the middle of the season. I don't have an answer for that.
Did you want to say something?
So I do want to mention one thing because my PhD was with climate models. So one important difference is that most weather forecasting, you have sort of a base climate that you can compare to. Well, for at least for endemic diseases, you do sort of have like a base rate that you can compare to. But for like new epidemics, for example, it can be very difficult when there's a lot of uncertainty about all of these underlying parameters and the underlying mechanics as well. So I don't have an answer, but that's also just one point I wanted to make.
I also think that climate models have a lot more rich data to leverage to train the models and help us understand what's going on. Whereas usually we're always behind with epidemics. Like Dr. Chen mentioned in her talk that, you get data on a day and then the next week they actually revise those data. Like they weren't actually very accurate. And so like your forecasts were based on data that wasn't very good. And that doesn't tend to happen with climate models as much. So yeah, Dr. Bento.
Thank you, all three of you, for your talks. They were very, very good. Just a quick reply to that. Yogi Berra said prediction is hard, especially about the future, right? But to your question, in my kind of experiences for weather, if you think it's going to rain, whether you take the umbrella or not is completely irrelevant, right? Whether for disease modeling, human behavior has a huge impact, as we saw from a lot of the talks. Dr. Chen talked about a lot about, how good the models are, and we see that ensemble models always do better, precisely because, as Joe was saying, the more data you incorporate, up to a point, you kind of get more data. But if, as we saw, if I take a mask early on during COVID, before the vaccines were implemented, or now again, I actually may have an impact not just on myself, but on a particular chain of transmission that it can happen, right? So little things, right? So my umbrella can actually affect kind of a progression of a particular transmission chain. So therein relies the fact that infectious disease forecasting can never be like meteorological forecasting, precisely because of that very specific sensitivity to actions. So that's kind of my main comment. But I don't want to steal the thunder from our colleagues.
Very good point. So I think we're going to conclude our panel discussion. So let's thank our speakers one more time. And now we have time for lunch till 12:15. So maybe try to come back like 5 minutes before, but lunch is being served right outside here. Thank you. Hi, everyone. We're going to get started with our afternoon session. I hope you all had a good networking lunch and got some really good food. So thanks, Nick, for ordering from an awesome food place. I'm really excited to introduce our second afternoon keynote speaker, Dr. Anna Bento from Cornell. And Anna is really an internationally recognized modeler that's worked on infectious disease problems from across the globe and was even hired to really lead international efforts during the control of COVID-19 that I think she's going to talk about today. And so we're really lucky to have Anna here, and let's welcome her.
Thanks again, Joe, for the really kind invitation. I'm very excited to be here. So today I'm going to be talking about a few projects that I did with a large group of people, right? So I'm standing here on the shoulders of many collaborators, many data collectors, many public health stakeholders and officials, and everybody that really kind of makes an effort on creating and making available of data, because as Joe said, I'm a modeler, so I do the easy bit, which is get the data and have some fun, right? So the work that I do, even though it's quite theoretical, always has this kind of very applied translational purpose. And it really kind of relies on this idea that a transmission of infectious diseases is heterogeneous. As we saw this morning, really depends on the spatial structure of a particular population or community or country or region. And as we saw from Pamela very clearly, is unequal in who gets most impacted, right? And what I find the most fun, bit perversely fun perhaps, is this idea of host behavior and how that actually impacts things. Hence my reply this morning to the conversations that we were having. So I kind of see my world has different dimensions on how I think about infectious diseases, either from an emerging point or from a spreading point or from a control and mitigation point. So in my group, we always start with this idea of, can we decompose an infectious disease system into specific types of dimensions, right? So if it's something already in human populations, which is what we're going to discuss here today, we always think about what kind of data relate to epimonitoring. So we have syndromic surveillance, we have electronic health records, we have all sorts of associated type things to do with who's getting sick, how are they getting sick, how severe it is, can we attach any more metadata to it, right? And then the other part of the work that I do is really kind of thinking about epidemiological monitoring from the pathogen point of view, right? So molecular detection. Is the pathogen evolving? How fast is it evolving? Is that pathogen evolution kind of hindering its way or enhancing its way of spreading faster in populations? And then the bit that I think has been most relevant for the first part of our workshop is really this idea of conditions for spreading, right? So now we move from things that happen to the hosts, to humans, onto things that depend on hosts or humans in this case, right? So we talked about a lot social determinants of health this morning, and this encompasses all sorts of things, right? So if we think about the US, which is where we are today, in case anybody's lost, thinking about as Jeffrey was talking about, different components of socioeconomic determinants, could be like educational, can be economic, can be cultural, and so on. And then, of course, proxies for some of these data, right? So social media data, mobility data, that are kind of crude approximations of behavior. And this can be idealized behavior, so what I think, or actual behavior, what I do. And those two actually are sometimes not in keeping with each other. And then the fun part that we heard about this morning, of course, the integration of these data, or triangulation, or all sorts of different lexicon we can use to talk about how we standardize our data, how we can kind of utilize data coming from different sources, collected in different ways for different purposes. And the point is obviously to do the modeling, right? So we use a whole host of different approaches in my group, from statistical modeling to mathematical mechanistic model to phylogenetic models, which kind of look at evolution of pathogens and how that affects transmission dynamics, with the idea of kind of always understanding hotspots, right? Hotspots are important specifically for emerging problems, and these don't necessarily need to be emerging novel diseases, but as we probably know, measles is on a comeback tour with a vengeance. So understanding where hotspots are is important also for seemingly endemic diseases as well that are kind of like having a bit of a comeback. So the questions that we ask normally is, what are we optimizing for? And I think this is an important question, especially for the colleagues, either virtually or in person here, that are state health colleagues that have to make decisions, right? We have fun with our models, but then we have the colleagues that actually have to incorporate the results of the models and actually have to make decisions. So during COVID, all of us disease modelers were like, yeah, so it's very easy to control something. You keep everybody at home, nobody leaves, and that's it, right? And then by the time we want people to leave, there will be a vaccine and everybody gets vaccinated and that's it. We know that's not true, right? We know that state health departments, federal decisions need to be made and they have to optimize for different things. While we were optimizing for no cases, no mortality, decisions need to be made on the balance of the economy, on the balance of infrastructure of cities, infrastructures of counties, infrastructure of states, tourism, all sorts of things, right? So what are we optimizing for is always our first question. And then can we incorporate an incentive structure within our models to understand, can we modify the course of an intervention if we create the right structure of incentives, right? So again, the COVID analogy is we wanted people to stay home, but most people in the US, for instance, do not have savings, do not have sick leave. So therefore, their behavior was not elastic at all. And what elasticity means here is they were not able to modify given a new problem in their lives, right? So this idea is really behind most of the work that we do. And then we always divide the kind of work that we do by detecting, which is kind of like something that is happening. So how do we detect it? Understanding, and then predicting or forecasting, nowcasting. And hopefully if I have time, I'll get to the forecasting, but we'll see how Joe is strict with my time. So this was the first project the second project that we did for COVID. And for the purposes of this presentation today, all my work is going to be centered on the question, the data we had available at the time, and then the models we were able to implement to answer or try to answer the question, given the information that we had available at the time. So early on in the pandemic, I was asked to join a World Health Organization technical advisory group, and this was about closures. So border closures, school closures. So we wanted to understand, is it useful or important to enact closures? So this was put in effect in April of 2020. So after of course, the declaration of becoming a pandemic, right? SARS-CoV-2 becoming a pandemic. So it was already I'm going to give you like the cliff notes. It was already too late, but we had to do the exercise, right? So the question was, when did SARS-CoV-2 arrive in each country? And of course, I'm not listing all of the countries here, but we can go through some of them. And the question was, in a way, who infected whom, but at the regional level, right? So who is exporting the most and when? So this, as I said, was April 2020. So we were relying on some molecular data that was already available, mobility data, so flights data, other types of transportation data between countries. We had started having, of course, some reporting, not everywhere, but some reporting. And we were relying on kind of surveillance and policy data. Policy data here was things like inside a country, how soon were they enacting mitigation strategies? So like stay-at-home orders or stay 2 feet apart, those kinds of orders, right? And then, of course, eventually border closure orders. So with these questions that we were tasked with and with the data that we had, because I was trained as an ecologist, our idea was, let's do a meta-population model. And a very quick crash course on metapopulation models is really kind of a spatial model, right? Like Jeffrey was kind of talking a little bit about spatial understanding of things. So we kind of have a source and a sink, and each of these little populations are connected to each other, and the link by which they are connected can be strong or weak, and that can change over time, and the flow between each node or each metapopulation depends also over time, right? So people moving from population A to B, the number of people moving at a given time doesn't necessarily need to be the same from B to A, right? Is this idea of flux and strength over time. And trying to play around already with some behavioral things, which is the idea of collective behavior theory, which is understanding that if I make a decision or a country makes a decision, how does that affect the decision of countries around it or people around it, right? So in this case, of course, was country. So we seeded our model with China. So this is why you see China only has a point rather than a confidence interval, which is the blue bar. So the blue dot here is the predicted first case. The blue bar is the kind of the confidence interval of our stochastic metapopulation model. So it's a model that has some uncertainty in it. The red dot is the first reported case in the countries listed here. And then the green ball is how many cases were there when the restriction of COVID the border restriction was enacted, right? So that's kind of like the idea, and this is the length of the timing of the restriction. So we start with China, of course. We estimated based on molecular data that it was likely that it had started November 23rd, 2019. This was from phylogenetic modeling. And so we use that to seed our model, right? So we're not estimating here anything. We're saying this is where the model starts. And then with our metapopulation model, we were able to kind of estimate when cases would have arrived in a given country. So for instance, for the US, we estimated it was probably arrived early January in the US. And we know that the first case was reported like mid of January. So it was actually not too farther apart from our predictions. But in some cases, for instance, Chile, because obviously Pamela was talking about Chile, our prediction was that it arrived more or less in mid-January, but for instance, their first report was a month later. And on average, most of the countries had about a month of delay of reporting from when the first case had arrived. And from what we know, of course, from COVID now, that meant that there was obviously a lot of internal transmission already. So in here, you can see that by the time of the first case reported, we had a very different number of cases, right? So for instance, again, for the US, when the first case was reported, and by the time that the borders were closed, we already had an incidence of 500 cases per 100,000 people, right? So the idea here is that the estimation of the arrival was much earlier than the first reporting, which is not surprising. But what I wanted to kind of highlight here is that despite the first reporting, and despite, of course, our estimation of when the first case might have arrived in a given country, there was about a 1 to 2 week difference, except for Saudi Arabia, of when countries decided to close their borders, right? So this was the thing of, if I close my border, my neighbor is going to close their border to me, right? So we started seeing this idea of a rollout of decisions, not necessarily based on evidence, but based on policy. So this idea of optimization again. So this was really funny to see, obviously, in a very perverse way again, that, you know, if we started looking at, so this is, of course, output of the model. In December 2019, China was the biggest exporter of cases to the world, mostly to their geographic neighbors. So Asian countries here at the top, and then we had, of course, Europe here, and some countries in Asia again here, and some American countries from the American continent here. But by the time we started, we moved forward in time. So by January, because China had started, you know, like really implementing very strict internal measures, we start seeing that other countries had started to export to each other, right? And by February 2020, which is Mardi Gras or Carnival, where China was completely closed off, Italy started to become the biggest exporter of cases. And of course, it was exporting mostly to their geographic neighbors or trade neighbors. But, you know, as time went by, Carnival was over, no more partying. And then by March 2020, we in the US were the biggest exporter of cases, right? And we were the biggest exporter of cases to our geographic neighbors, so Mexico, Canada. So we see this kind of very interesting trades and behavior of the countries for which we did not close the borders to, Mexico and Canada, were actually the ones that we were trading most cases with. So far, so good, right? Nothing that I'm telling you seems a little bit strange. So here was the main result that we presented at the technical advisory group, which is, and I'll walk you through these plots. So the bottom one is the local transmission, the probability of local transmission. The top one is the probability of imported cases. So the darker it is, the less likely or less probable it is in this case. The lighter color is the most probable. So we see that, and then the first line, the red line, is the first day of the most important mitigation strategy internally, and the green line is the first day of official ban implemented by the government. So in the US, by the time the measure started, so in fact in the US, these two happened with like 2 days of distance to each other. There was actually no kind of immigration cases being impactful to the local transmission, and everything was autochthonous or local transmission already. Here at the top, we have kind of the monthly imported cases from different countries over time, and here is where we are importing as well. So kind of like a more kind of temporal way of doing it. And you see that as time goes by, so we were getting stuff from China, and then at the end we were getting stuff from Mexico, Great Britain, Canada, so all the countries we hadn't closed our borders. But the point here is that by the time the US closed the border, it was too late, right, to actually utilize that measure. Mexico was the same, Italy was the same, Spain was the same, and surprise, surprise, everywhere else in the world was pretty much the same. There was no country that implemented these strategies early enough, right, such that it would have had an effect. But that was the major policy, international policy that was implemented, right? So we had to go back to the technical advisory group with the news of it's too late, right? Don't do that anymore. Like just relax the borders because it's not doing anything. But once you close the borders, it's actually difficult to open them back. So there was an inertia in the policy to allow for, you know, things to go back to normal. So I'm going to switch gears and move faster in time to another emerging problem, this case a little bit more local. So Oropuche is a vector-borne disease that is vectored by a midge, so Culicoides pareensis. So it's a tiny little midge that you barely see with your naked eye. And it's been around, so this is the Amazonian part of Brazil, and it's been around in this area for a while, but it was kind of having like 1, 2 cases, 3 cases every year, and then it would die off. So your typical spillover event, because the wildlife reservoir is a sloth, very cute animal that people love to hug. So there was these occasional spillover events, but you know the outbreaks would die off until 2022, when we started seeing, and then here is so here we have precipitation and temperature, but just to give you a kind of idea of seasonality and things, but I'll get back to this. So until 2022, and so for some reason I got this cut off. So it's the same timeline. From 2022, we started seeing that dengue, which is the major culprit of disease in Brazil, vector-borne, that was kind of dominating most of the cases of vector-borne diseases in Brazil, kind of started dying off in this region. And the pink one, which is dengue 2, kind of took over, typical dengue things. But in 2022 is here. At the end of 2022, we started all of a sudden seeing Oropuche cases, kind of invading the Amazon. And I say invading in a kind of funny way, right? But it's this idea that no virus or no bacteria exists alone in the context, right? So there's like a space where they coexist and they compete, especially when it's vector-borne diseases, even though, of course, these other vector-borne diseases are vectorized by different vectors. So the idea was, so what's happening, right? Did the pathogen change? And so in collaboration with virologists and epidemiologists in the region, our question was, is the virus evolving? And we had a lot of genomic surveillance data, epidemiological data, and of course, weather data. And for this purpose, because our question was from the pathogen point of view, we wanted to understand what was happening to the pathogen. So a file dynamics model tracks virus evolution over time, in this case, and while dynamical systems transmission models tend to look at from the past to the present, in file dynamics, we use from the present to the past, right, to estimate backwards what's happening to a virus or a bacteria or so on. So two things we were able to see. So here is the effective population size, and effective population size is akin to a reproductive number. So it's the number of genomes that give rise to the next generation, right? So in an epidemiological sense, we think of reproductive number as the number of cases that will then allow for more cases to come in the next time step, right? So it's the closest estimation that we have from genomic data to a reproductive number in a way. So the first one is a particular, so I forgot to mention that this virus is kind of segmented. So this is one of the segments of the virus. This is another of the segments of the virus. And we could see that in the Amazon, we could see that one of these segments that we discovered that had reassorted was having this kind of like increased transmission. So increased diversity in 2023, and it kind of went up and down, still seasonal. However, one of the other segments in this virus, we started seeing that at the end of 2023, kind of started taking off. So we realized that this particular reassortment of the virus had really changed and perhaps was better at infecting people. So what we did was spatially, again, trying to track how fast the virus was spreading, right? And we could see that this virus that had some changes in this part of the segment was really localized in the northern part of the Amazon. But the one that was kind of related to this other segment of the virus that also reassorted was kind of spreading already almost kind of outside of the borders of the Amazon. So we kind of started thinking about how fast are things spreading, right? So we then were able to calculate two things. We were able to calculate how fast the virus was moving around. So where the virus was moving and how fast it was moving. And with these kinds of models and looking at this type of movement, we were able to calculate two things. The rate the virus was moving at two different rates. One was about 1.2 kilometers a day, which is more or less how fast a midge can move. So it was this idea of like, this could potentially be attributed to how fast the vector is spreading around. And then we were able to calculate for this one that was about moving about 30 kilometers a day. So linked perhaps with this idea that the spread could possibly be linked to human activities. Like Jeffrey was saying, phylogenetic models are kind of more statistical in nature. So this is perhaps it is. So we're now doing mechanistic models to really understand this. However, the point here was that this work was because it was in collaboration with the state health department, we were able to deploy faster diagnosis and target campaigns for the vector together in a co-creation campaign with the local authorities, kind of from a bottom up, right? So that was like the major thing here. So I only have 2 minutes, so I'm going to speed on the understanding. But I think that perhaps at least Joe and Jeffrey and I should talk a little bit about this at some point. So this was work that we started when I was at Rockefeller. So in 2021, I was asked by Rockefeller Foundation to create a computational lab inside Rockefeller to deal with SARS-CoV-2 response, both in the US, but most importantly in low middle income countries. And when we started looking at the data for COVID in the first year, my question was, is it really an urban and rural problem, or is it more of a community problem? So we wanted to understand why did some counties get COVID later than others? And you can see early is purple, late is yellow. And does the actual network structure of these communities matter most than their label of urban and rural? So for that, we were using the same type of data that Jeffrey mentioned. But in addition, we were using digital health records, purchasing data of over-the-counter medication, mobility data, and of course, we were using social determinant data like vulnerability index that is available through the CDC or was available through the CDC, and of course, the rurality index, which I'm sure Jeffrey was also using to determine. And here we were using network models and community finding algorithms and regression mixed effects spatial models. So we were able to kind of cluster by the arrival time all of the different counties, and we identified 8 clusters. And all of them had some components of urban, which is orange, and rural, which is blue. But we started looking to see that they weren't that different, these clusters, in terms of components. So, and like Jeffrey, we were also looking at, how it wasn't that different early on in terms of cases, but actually later on, towards the end of 2020, there were actually more cases in the rural areas than in the urban areas. And we started associating that with behavior, right? So the baseline here in mobility is 2019, which is dashed, and the solid lines is the 2020 year. And we see that during the lockdown, there was a definitely dip for both urban and rural, but rural actually went back super fast to their older behavior, but that still was not really explaining a lot of the risk, right? And here is our decomposition of, the same as the early map, trying to understand how connected was this network in relation to the country, right? So the closer the dots are, the more connected they are. The ancillary faraway satellite dots are communities that are kind of more disconnected to each other. But by the end of 2020, we do see that both urban and rural communities are pretty much connected in terms of their risk. I think I'll stop pretty much here, but here is kind of a decomposition of the cluster. So here is urban and rural, and you see that there's a mix of connection regardless of urbanization or ruralization. But when we start thinking about risk, we do see that risk kind of evolves kind of from a centralized network at the beginning to kind of spreading like a disease, of course. But when we start looking at social determinants of health and community structure is where we start seeing the important parts of the transmission, where we see that less vulnerable counties were kind of more together to each other, and the more vulnerable ones were kind of separated in terms of risk from the network. And end here because I picked Arizona as one of our communities to show you. So what we did then, because we didn't think it was an urban and rural problem in terms of spread, was to try and use community detecting algorithms based on all of the data that we used to start understanding whether, if you are in a border county, for instance, whether you're actually more likely to behave like your neighboring counties, regardless of being in a given state. Right? So our community one here has a lot of counties from Arizona, but we have a New Mexico county that actually is behaving as if it belonged to Arizona. And what we see here is this idea of the weakest link, right? So we start seeing that incidents entered this community in the Apache County and kind of started spreading all the way to the rest of the community. And I'll be delighted to talk a little bit more about this in our discussion. But then we did some regression analysis to identify this idea of the weakest link. So your community is as resilient as your weakest link county. And this is not, and this was kind of framed as, this is not to create a villainized weak county, but to understand that your strategies need to be in the vulnerable counties, in the vulnerable communities, immediately, such that your whole kind of conglomerate of counties can actually be more protected. I won't do the predicting forecasting because my colleagues already did an amazing job this morning, so I don't want to embarrass myself. So I'm going to skip this and we can talk about it later, but I'll end with the challenges, which I think will be important for our discussion, which is this idea of it's all great if we have a lot of data, right? But some of these modeling approaches are really data hungry, which means that sometimes in low middle income countries, makes this kind of work a little bit hard, right? But not only that is this idea of lack of standard methodology, lack of legal frameworks to share across borders, which kind of affects this idea of how can we actually share data. And it really is this idea of how do you keep data safe. Pamela talked about identifiability, which is really important, but it's to me is more about data sovereignty and how we use these more novel ways of sharing data that keep sovereignty and allow for sharing in a safe way. And with this very grim message that we don't share data enough and we don't collect data enough, I'm going to say thank you and hope for a good discussion later on. Thank you.
Thank you, Anna. And we'll save questions for the discussion, but there'll be plenty of time for that at the end. So next, I want to introduce Dr. Sanjay Mehrotra from Northwestern University. And Sanjay is really an international leader, I would say, in optimization and resource allocation. Things like how do we distribute vaccines? How do we distribute organs in terms of organ donation? Like how do we optimize the movement of organ donation? Things like this that really make applicable these models to public health questions. So thank you for joining us, Sanjay.
Well, Joe, I'm really happy to be here, and I'm actually happy to be part of the EPIMORPH project, because in many ways, this might actually be one of the early demonstrations of how we can integrate technology from a decision-making technology perspective, something I've worked on for a very, very long time. All my hairs became white working on those things, into public health decision-making. Just as a way of my own background, over the years, I've worked on bleeding edge of optimization methodologies. So that if I was to go back and say, where is my core in terms of what I do for keeping my brain neurons working, I do that. And this work actually is at the bleeding edge of what I think could be the next technological advancement from decision-making perspective in decision-making overall. And that's the broader umbrella in which I've worked on over the years. The work actually has a background of a research paper that I had done with a graduate student of mine that led me to talking to Joe and Esma and became part of our motivation for doing what we could be doing. So overall, I do decision-making under uncertainty and decision-making where stakeholders could be involved as part of the process. And as been said multiple times earlier, we have data, we have data based on which we've done some kinds of forecasts, and we have some decision makers on the other end, policy decision makers in case of Anna's talk and in her engagement, who are wanting to make decisions, and I want to work in the middle to bring science towards that decision making, well aware of the fact that there are issues with forecasts, there are noises with data, there are all kinds of other issues that are part of the data that we need to handle as part of the modeling. And then there are also issues on the decision makers side in terms of then having different viewpoints, different priorities and all of that, and then still work under that sandwich to see if we can actually put some science behind it. So if you can think, in a purely non-political scientific world, if everybody can come together, can we really do it? Okay, so that's kind of the broader framing. And if you think about it, vaccine facility location is just an instance of that in which things can be happening, and utility is one of the drivers that is going to ensure public health entities coming together and helping make the decisions. So think about state of Arizona. In this case, you are a public health administrator.
Oh, thank you.
You're participating in a situation where you anticipate a limited vaccine supply. So it's not in abundance. Or you may even have extra supply, but you really don't want things to be wasted. So either is fine. For now, it's limited vaccine supply, and you really can't distribute this vaccine supply to all qualified health service locations, for example, pharmacies. And on all the dots in this map are basically the locations of different pharmacies in the entire state of Arizona. Okay, and I just generated it while I was preparing the slides through the data that's available. I think that, this is just generated by some AI tool that was available online. So they just did it for me. And really, your goal is to ensure an equitable distribution of the supply. Okay? And these are all kind of loaded phrases here. And the question really is, how will you do it? And what's going to be the science behind doing it? Okay? So the science is my job in a way, and how you would do it is your job as a public health administrator if you are in the audience. Okay? All right. Let's just put it in the personal context a little bit. I just went to get a allergy medication. Went to the closest pharmacy. I needed to go there because I needed to come back to the venue to give my talk. Somehow the allergies flared up as I was sitting in that back corner and was going back out and sneezed like 30 times in the 2 hours. And disturbed just about everybody who's sitting in that back row there. So now you are a customer. Just completely change the decision domain for the time being. And you, for now, assume that shop at Walmart, and you've got multiple Walmarts in your vicinity. Okay, and your issue is which Walmart you would shop at. Depends on really the location where you live. the proximity, but oftentimes a bunch of other criterias. So overall, you have all these attributes that would come into you helping make your decision in terms of where you would go for the next. And there are all other dynamics that might be involved, but at least at the very least, there are going to be some factors that are there in terms of where one would shop. In case of me, I mean, I just went to the closest pharmacy, but at times, if I was back in my hotel room, I may have checked around and might have gone to CVS or Walgreens or whatever. That was more, conveniently available and where I shop, etc. Okay. Now, when we did the work, again, Illinois was mentioned before. So this is a map of basically it's a zip of, in this case, 20 plus candidate vaccine center locations in 5 greater Chicago counties. So Cook was mentioned before. It's Cook, Lake, I believe it's Will, and a couple other, I can't remember now. I think it's on my later slide. And again, the issue is me going to particular pharmacy in this case, which is at a certain distance from where I live, to get myself vaccinated. Okay, and this again, my personal life, where I made the decisions as initial. I mean, I'm aging, so as initial vaccine supply became available, I could schedule myself driving about 70 miles from where I live to get vaccine more or less the same day. And I could schedule in certain specific zip codes where the vaccine was available, but I could not get vaccine available in the reasonable proximity of where I live. So clearly there was a mismatch of supply and demand in the early phase of how the vaccine distribution happened to different pharmacies around the place where I want to live. And I really want to make sure that I'm making that decision in a judicious manner as an individual. So it's a personalized decision making, but at the same time, from a public health perspective, the administrators are making decisions to ensure some degree of equity in that decision making. Okay, so we had some kind of rough way of thinking about scientific, broadly framing scientific definition for the problem, but then thinking for now, from equity perspective, ensuring some degree of herd immunity and doing that herd immunity in the context in different geographic areas or populations living in that area over time. And we all understand what herd immunity is and so forth. So once again, drilling it down a little bit more, we have some utility effect of location decisions in terms of how much supply we're going to have at the locations and which locations we will be having the supply, which may depend on the population size, my personal decision, distance, the demographics of that area, other sociological factors, and hesitation for vaccination and so forth. So all of these are attributes that eventually can be bundled in to a functional form. And I'll just call that functional form to be the utility of an individual living in a particular geographic location for that individual's utility for going to a particular location to get vaccinated. Okay. Now, the concept of utility comes from economics. I mean, it's been very well studied in economics from the Nobel awards given on the topic, and also, of course, well studied in marketing, product marketing, and to some extent also in healthcare. All right. Now, the situation here is a little bit more complicated than what happens in typical economics, because if I was to actually make my decisions about as an administrator, I'm wearing that hat, and I have to make these decisions at one time and phase these decisions over time. So I may start with a subset of locations add new locations. But initially, let's for the moment assume that I'm just making a subset of decisions now. Then an individual's utility is really impacted in a nonlinear way on the location decisions, which I have not yet made. So this notion I'll call decision dependence. So if I knew where the location was and I can ask the question from an individual, then I would know this individual can tell me, the utility, but I haven't made the decisions yet. Okay, so I've some ways of estimating some of these things, and again, there's that part to it, and we've got some ideas and some work on that. But for now, this whole thing gets kind of embedded as part of it. So as you can imagine, from an optimization perspective, as a pure methodology standpoint, these problems do get complicated, and that's what we've been working on in the last couple of years to wrap our brains around and hands around to see if we can do them in a meaningful way. But as later part of the presentation, I'm going to try to show you the relevance of this in the context. Okay, so there is that decision dependence about, depending on whether I've opened 2 units or 3 units in this simple example, but out of 20, 5 or 7 and where they are. You with me? Okay. All right. Now, there's another complication here, how this utility function be behaved. And the utility function should be behaving as a nonlinear utility, as mentioned that before, because the incremental value should go down of having more and more. Okay. The herd needs to be captured in a way so that we can actually wrap our hands around how we'll be encapsulating that in a meaningful way from how much supply we will provide or where we're going to locate. So there's a function called Lambert function that's been proposed. Depending on the vaccination rates, this Lambert function can actually try capturing that. So we used it as part of our modeling. And then I'm going to skip, this is details, so let me skip the math. And then the optimization model, let me skip the math. Skip that math. It just gets uglier and uglier. And it can even get more ugly if I actually had more technical slides. We keep doing it. We keep doing it. Those are the 5 counties, Lake, DuPage, Cook, Will, and I think it's Kane, okay? From which we picked the zip codes. We picked the data, estimated the utility. We got data from Illinois IDPH also in terms of vaccinations and so forth. Try putting all of this together and have the results, okay? So just to get your sense of without the herd immunity in the model, this basically shows, if I was to use this linear utility of this, I guess it's a 20 location example, where I'm just selecting 5, where you actually have these blue pinkish color coded, not the red ones. Red ones are feasible. The locations are just 5, so you could just spot those. You see the decisions change. And those of you who are familiar with Illinois, you see in this case, there was a facility that opens up if I was using concave utility up north on basically is west of Northbrook is Winnetka, Wilmette, like closer to the northern, northeast suburbs, if you like, of Chicago. Which otherwise you would be opening, you're just using linear utilities, you end up having 2 pharmacies very close to each other in the city. Okay. Now that was the effect of, go back here, concave utility. Now, if we use the herd effect, that again kind of shifts a couple of these facilities to different locations up north. Okay, so how we model and what we incorporate in the model does have an impact on the locations that will get recommended from the model, assuming you believe the data that's going underneath. This one is an example with 10. Once again, you see there are changes, and I can go into, if you know the geography in terms of the geographic demographics, because of the income differences and so forth, why some locations will make more sense as you make the model richer and richer in its decision, because the geography of Chicago is very special. Right? There are population centers in Chicago that are underprivileged, and the population centers that are greater privilege. There's greater distances, density, and so forth in terms of how the populations are. And all that data had gone into the utility estimation. Again, from an equitability perspective, once again, as you bring in the herd immunity, you're seeing those effects. But with that, I want to stop. The point being that I think from a project perspective, we are beginning to be at the bleeding edge where we can start bringing in some of these even more advanced methodologies that can be used to demonstrate how we can incorporate more scientific decision-making for what Epimorph has been building from a projection perspective. Thank you.
Bringing up the slides here, I just want to introduce our next speaker who's joining us via Zoom today. Okay. But we have Dr. Michael Simeoni from Arizona State University, who's going to give us a little bit different flavor of talk. Michael is a social scientist, and I saw him give a talk at ASU about a year ago, and it was really captivating, and talked about how we can think about aspects of culture and link those to the models that we might try to be building as epidemiologists. So thank you, Michael, for joining us, and we're really excited to hear your talk.
All right, yeah, thank you so much, and thank you for having me. As stated, my name is Michael Simeoni. I'm in the School for Complex Adaptive Systems at Arizona State University. I am not an epi-modeler. I am a kind of social, computational social scientist, and I'm interested in the quality of information environments and trying to model those. I think maybe the thesis of this presentation is less me showing off a completed model and more kind of sharing, on the one hand, some of the contingencies and kind of considerations we should have when trying to think about our information environment as part of any kind of larger scale model, including an infectious disease model. But then also to beg for help and assistance if anyone is interested in trying to create a more responsible epi model, or I should say more a sensitive epi model that's more sensitive to some of the contingencies I want to highlight. And so while there are some ideas that I'll present today, a lot of this is very much work in progress, or at least the final part is really indicating some work in progress. So here we go. So yeah, what I really want to do is talk about how we can model this idea of an infodemic at the same time that we might be trying to model pandemics. And I'm also noting that I've got 10 minutes to go, so I'll try to keep this pretty tight. So yeah, I mean, I think a lot of us have been exposed to this idea of the infodemic. I just have the World Health Organization's definition of it, although there's a lot of different in the space of mis and disinformation, in the space of kind of human-computer interaction and kind of social media analysis and computational social science. People may vary in what they mean by an infodemic. But I think in general, what we want to think about is one thing that was very interesting about the COVID-19 pandemic was that it was coincident with some interesting kind of developments in technology and how that's used in communication technology and how that was used to distribute information. And there's still some kind of unanswered questions about exactly how that affected people's behavior. Or if social media is more of a kind of index of what's happening or a predictor of what's happening. We don't exactly know in every single case, especially in this context. And so something that's interesting is a lot of times it's really easy to kind of fit into a kind of communication model. If we're trying to think about modeling communications, that we've got one person, this is just an oldie but goodie, right? This is 1980. At the time, this was like kind of mind blowing for cultural theory and communication theory. This idea that you would encode a message from the receiver would encode a message from the sender through some sort of ideological lens, and then they would re-encode it and pass it on. That seems really simple on its face, right? And a lot of times we like that sender-receiver relationship, even when thinking about networks of communicators. The interesting and tricky thing to think about can be is if we're passing that information along after it's been encoded from a particular person's perspective, and keeping track of what that message is can sometimes be really difficult. And I mention this just because sometimes our models for how people are actually spreading misinformation, we want to be attentive to the fact that it's not as easy as just there's a quantum of misinformation and I'm going to pass it on to somebody else, and now they have that quantum of misinformation. I think this has gotten more sophisticated over time, right? So we're trying not to just think about it as, did someone send you misinformation or did you click on fake news? And there's a whole literature, obviously, on how to measure if somebody actually has been affected by content that they encounter online. And then there's also, stuff we want to be attentive to as well, that not everybody gets information online, or someone may be exposed to information online, but they spread that information in non-online spaces. I really like this, at least, typology of different ways that nodes can be related to each other in a communication network, virtual or social. But I would recommend, or I would commend to you the idea that these things can all be happening all at once. That there isn't necessarily always a correction. That dissemination may vary considerably, and that all these things are happening all at once. It's not just a life cycle. Also, something that I think is really hard to model is this idea of social epistemology. And that is, we do not process information as individuals. We process and make knowledge as groups and collectives. And when those groups and collectives exist offline, and we're just using online information, that can be really confounding, especially when we're trying to model like behavior and assumptions. So look, on the one hand, we know that people are being misinformed grievously about the conditions for a given infectious disease based on recent information. However, if we just want to model it online, we should proceed with a lot of fear, trembling, and humility, because we know, and because there's a lot of good information about how people tend to form knowledge and beliefs. A lot of times, and a lot of the work that I do is on mis and disinformation. We don't think about somebody as coming into contact with misinformation and suddenly that misinformation transforms their perspective. There's a lot of things that kind of exist as prerequisites in order for that misinformation to circulate. And oftentimes there's interesting cases where people may spread or share this information and they might not actually believe it, but they spread it anyway. So again, trying to rate who believes what and who's sending what and who's come into contact with what can be a big tangle. I think there's a couple concepts that I think are really helpful. I really like the idea of truth decay, and this comes from Rand, but just that you're trying to rate the overall quality of an environment. That truth decay is just kind of a global variable, if you will. So rather than focus on what exactly is being sent around at what particular point, we're just trying to understand the conditions of the environment. Do we have kind of high trust in institutions? Do we have kind of consistent practices that lead us to something that we might believe in as truth, lowercase t truth, not like absolute truth? And then also as a reference to another paper that some colleagues and I have written on just trying to understand what misinformation is in the first place, right? A lot of times we think about it as, fake news or not fake news or true or false, but there's actually like a really interesting kind of continuous relationship for misleading information. All this has kind of pushed the field of misinformation studies to think more ecologically about misinformation, right? I think a while back, maybe 10, 15 years ago, epidemiological models were really popular for misinformation. We would use social media as the network, and then we would try to think about social media or misinformation or fake news as an infectious disease that spreads throughout a social network. I think now people are starting to think about these as ecosystems that have kind of durable qualities to them or more longstanding qualities, and it's not like an infectious disease, that might not be the exact metaphor to use here. And I'm very persuaded by that, and I think it can be influential in the way that we think about how misinformation or an infodemic might interface with a model that's trying to understand a pandemic. We have two basically interdependent systems. We have one that's physical, biological, et cetera, and immunological. Another one is kind of digital, has virtual characteristics, right? This is also a bummer, is that infectious disease works in real space, but virtual spaces means that sometimes we might be trying to measure a signal that isn't necessarily local to a particular area, but it might still affect other areas that are not local to it. There's like limited location data that's disclosed in a lot of social media, and social media is getting more and more difficult to access in terms of some of the richer metadata that might allow us to make those judgments in the first place. This kind of stuff isn't exactly new about trying to figure out how to get behavior into any kind of infectious disease model. For me in particular, though, I really want to push this idea that misinformation is less like a disease, and it might be more of an overall condition of the environment. Rather than get hung up on who's believing what or who has come into contact with what, the approach that I propose based on this kind of movement and based on some experiments that we've done is to really think about misinformation not as another disease or as something that's going to spread explicitly on networks and we have to model those networks or we won't understand it, but to try to understand it as a more global condition of the environment. There's some advantages to that, and then obviously there's some disadvantages to that. But a lot of the confounds that I've mentioned at the beginning indicate that just because social media is available to us as network data doesn't mean we always need to think about it as network data. It kind of pains me to say that sometimes because I spent a lot of time evaluating social media as network data. But in some ways, it can disclose qualities of an environment. And a lot of kind of social and cultural theory already treats, different kinds of cultural artifacts as dispositive of certain qualities of a culture, contemporaneous or in the past. And so we want to think about this misinformation as a kind of signal that might be globally applicable to different environments that we're trying to model infectious disease. So one of the things that we're working on right now is to try to go back to that time of flatten the curve, kind of March to October 2020, where people were instituting some of these kind of first waves of lockdown and kind of countermeasures. It was very much in the discourse to think about the epi curve as like a thing that people like tweeted about, and then how to take care of that. Now the tricky thing is we collected every tweet from the Twitter stream available to us, made available by Twitter, right? So we have a lot of tweets on our research server, and we've analyzed some of them. It's impossible to kind of create a kind of rich network that's going to tell us stuff about who's spreading what and when, because that's only on Twitter, right? And we can't expect it to have more representative value than it has. But one thing that we're very interested in is a sort of, rather than an epidemiological model about Twitter, is trying to think about it as what information is out there. When I say this, I just mean I'm having to race through this, but we're looking not at spread, but prevalence. And the basic way that this breaks down is we take samples of daily Twitter files that we've collected over time. We downsample that into like a stratified random sample over the time of day, and we include retweets. Then we do some topic modeling on those tweets as a way to extract different themes and topics. And then we have a kind of dictionary-based method to identify just conversations about topics that we think are going to contribute to truth decay. We're not interested in if it's real or fake. We're not interested who says it. We just want to look at what are people talking about. And so our theory is that if people are talking about ivermectin, then that is an indication that we have some truth decay, right? If people are talking about hydroxychloroquine, no matter what, if people are fact checking it or not, right? That is a dead giveaway that this information is kind of part of public conversations right now. And so that's what we're trying to measure, that sort of zeitgeist. And so what we do is kind of transform this into kind of an information environment rating and convert that as a signal 0 to 1, and then try to pass that into a model or recommend that as a way to modulate a model. So here's one downsample that we took to try to look at the all the kind of conspiratorial or truth decay topics over time. I've got a red line on the kind of July spike during 2020 of where cases went. One of the things to continue is to sample more and more tweets to be able to get kind of more reliable assessment of what's going on here. But I only show this chart because there isn't necessarily going to be, or we're not counting on, and it's yet to be seen, is there a kind of predictive value to a lower or higher information environment rating, or does it kind of index exactly, or is it a lagging indicator, right? If we were to just trust this result, we would see that like talking about hydroxychloroquine, ivermectin, Chinese government conspiracies would be a lagging indicator of some of these things. But again, I don't consider this to be a representative enough sample to draw that kind of conclusion. I only share it to say that I'm not committed yet to exactly what relationship there is between the rating of the information environment that we can detect on social media and what we're actually observing in terms of trends in the infectious disease. And that kind of opens up to, I'll skip over this because obviously we can plug this into an SEIR model and modulate something like the beta parameter, and okay, cool, we get two different models. That really doesn't mean anything until we validate the relationship between, say, the IER or information environment rating and actual cases that we're able to see through now confirmed historical data or better quality historical data. Some advantages to this is that that information rating is something that's flexible. This approach is something that we could even do qualitatively daily by experts if we wanted to. The idea here is not only to try to think about a different way to model an information environment besides explicit spread on social media networks that we measure by retweets and likes, but also to kind of allow us to rate the information environment in a way that doesn't make us dependent on the kind of capricious access to different platforms, and to be able to make assessments with other kinds of expertise. And then it also kind of helps account for inauthentic behavior. So instead of just looking at specific users, or wondering if a user has been exposed to fake news or not, and then we're trying to figure out who's bots and who's nots. All of this actually treats inauthentic behavior as part of that information environment instead. So rather than trying to figure out who's been exposed, we just look at, again, that overall environmental rating. And then there's some future work about things that we'd like to do, especially trying to understand the relationship between that signal, that information environment rating, and historical cases, and try to make some inferences about what the proper relationship is between those two things, and then pass that into a high quality infectious disease model, and try to horse race that against, say, a default model, and then one that's modulated daily with daily averages, derived from the information ecosystem rating that we talked about before. And with that, just trying to speed through and leave us some time for Q&A. Just thank you to my collaborators. Here are some of the people who have funded this project over the last couple of years, and I will conclude there. Thank you all so much.
Thanks so much, Michael. I think we'll take like a 2-minute break and then have the speakers come up to the front, and I'll modulate a question and answer session. Thank you. Or maybe we don't need a 2-minute break. So no one's moving. So maybe Sanjay and Anna, if you could come to the front and we'll do some question and answer.
So my question is for Sanjay, and it was about, you were talking about the utility function for how people would choose which pharmacy to go to. So for the linear utility function, would that mean that somebody with multiple pharmacies they could go to would have like a higher utility?
That is correct. So remember, the function is depending on number of locations that are open after the decision is made,
right?
For which locations you'll be opening. So think about the following. I have say for now equally distant pharmacies. You open one, my utility is going to go up like that. If you open two, it'll go up incrementally more, but having two that are equally distant may not be as beneficial as one. So if there was the benefit was going up at the linear rate, they'll become linear utility. But if having two is not as much, not twice as valuable, as, let me go actually example of 3. So 3 times value for having 3 locations versus having less than 3 times value of having 3 locations is the difference between having a linear utility and a concave utility, right? So I'm not sure if I'm answering your question, but
that's perfect. Thank you.
It's a linear function versus a function that is not behaving linearly. And that was part of the innovation, if you like, from a pure modeling perspective that doesn't even exist in the decision modeling literature that exists in the space. And to be honest, in a broader optimization space.
Thank you.
I wanted to ask a question to Anna. That was really impressive, like the amount of analysis that you showed, Anna. So thank you so much for that. The predicted first cases in each, country, how did you come up with that? And the bar, was it the confidence interval around that point,
Yeah,
around that date?
So this was a stochastic SIRS model that was spatially explicit. So we have meta population, so each country was one population, and they were connected by flights, right? And or other type of transportation. So in each population, there was a transmission model, right? And then the connection between each population was the probability that in each daily flight, there was an X amount of people that were infected and they would arrive to the next population and so on. So we had every country in the world connected by flight data, daily flight data, and we had case report data or genomic surveillance data, policy data for each of these populations to allow us to do the within population transmission model to estimate the number of cases, to estimate the actual infected cases, because obviously case reports are only a proportion of the cases. So we were calibrating our model with the case reports, but we were estimating what we were calling true infection, right? So, and so we had that. We also had an asymptomatic category compartment in our model. So we were allowing people to travel that didn't know they were ill, right? So the model was an underlying SIR model that was stochastic to give us that noise, hence the uncertainty of when the first case actually
For
started.
every flight, you were assuming a bunch of people from, let's say,
The source
Mexico
data.
were
Yeah.
going. the
Given
source were
given that
going to the
dates,
sta-
yeah.
Yeah.
Given they
So
March
You
20.
didn't really consider whether they were returning to their home countries.
So we had that information, right? We knew who was coming from
Oh,
where.
really? Okay.
Yeah,
So
so
you knew the
we
official
didn't know their
countries of
names.
each
Yes,
traveler.
yes.
Nice,
So we
okay.
didn't know their names, but we knew
Okay.
where they lived.
Okay.
Yeah.
And how far back? Like from December 2019 or?
Yeah, so we had flight data. So we had baseline flight data since 2018 to calibrate our
Wow,
meta population. And so we had flight data from then.
Yeah, that was some amazing data that, like you showed analysis also. Thank you.
Thank you.
No, actually, I was going to add to answer that I gave to Jeff, just to give you a little more fleshed out version because I didn't have enough time for that. The way the modeling structure is, it is also allowing for not knowing the utility precisely. So if you're alert, there's one of the big issues in flags. So, well, the estimation of these things for heterogeneous population can be a issue. So the actual model that is in there is allowing for that ambiguity in utility assessment. But
So each of you have questions.
Oh,
So
sure.
the first one is that So I see that when you choose the 5 or 10 locations out of 20, I see the number of the possible combination is 15,000 more than that. Also, almost like 184 something like 1,000 different combinations possible.
Correct.
So how do you? I mean, did you use some specialized algorithm for just for that one?
Absolutely.
And
Oh,
what's it?
absolutely. This is that's another very, 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 very technical talk. There's a lot of algorithmic advancement that is exists in the literature at all, that goes underneath in terms of being able to do this. So you're definitely not exploring all these possibilities using a combinatorial exploration. You're really doing it in a very systematic algorithmic framework, which very broadly speaking, I'm not sure it's going to get into a little bit of optimization lingo, is in the context of what we call two-stage distributionally robust, or in this case also functionally robust, stochastic discrete optimization. So it's really very, very technical, and there are really the results that I presented here actually build off a paper that is under, not even that particular paper. This is beyond that paper, but the paper is right now at a very advanced stage of a second review, not even published yet, in a advanced mathematical optimization journal. It's actually #1 tiered optimization journal. So it's really advancing the methodology underneath from some of these results that we had. And the goal really is to even scale it up to much larger problem sizes. So there's a lot of algorithmic innovation that's going underneath.
Okay. Another question is that for Anna, is that, so you showed us some slides that categorizing many differences into 8 different clusters. So what's the criteria you used, or what method do you make those 8 different clusters?
We were using time series analysis to calculate the peaks of when the first peak and second peak during the first year of the pandemic started. And then we were kind of utilizing machine learning algorithms as well. So a bunch of them actually to calculate exactly when the peaks were and how well they were aligning. So then we kind of clustered them with random forest and boosted regression type clustering algorithms to let us understand which counties belong to which cluster. There was one cluster that had perhaps less defined kind of communities, right? The last cluster. These were normally populations that were very small, which are always harder to understand in terms of the dynamics, because fade outs are more common. But in general was a mix of techniques, kind of ARIMAs and machine learning algorithms to clusterize initially.
Okay.
Yeah. Before that, I just want to make a comment to Michael. I don't know, Michael, if you're listening. Yes.
I'm here.
This is me. I really enjoyed your talk. I perhaps have 2 recommendations just before. I can also email you. So rather than a typical transmission model, it might be useful to look at birth-death processes that are less disease specific, and really look at transmission from an idea of generation of the next case. So that's used a lot in evolutionary processes, and that might be useful. And for your plot that you had, that kind of like almost event-based line, the July peak of cases, the last plot you showed, that you were saying, oh, perhaps use of ivermectin or something was lagging rather than, it seemed an interesting plot to me, but I would recommend using early warning signal methodology, which is statistical approaches that look at the critical slowing down of a particular time series, and then you can extract statistical metrics like increased mean, increased standard errors, and so on. So there's very interesting statistical metrics for time series from the early warning signal that I would recommend that you use for that. But for the transmission, I would use a burst test process, but I can email you more about that. I just didn't want to not say that.
Yeah, that's terrific. Thank you so much.
Dr. Bento, I wanted to ask you more about the policy environment. Most social and structural determinants of health are determined by that environment, which are historical and contemporary. And I was curious, just your thoughts on how do we incorporate these historical policy decisions that are culture, that create this culture or this structure to maybe predict or slow or get there before it's too late, I guess. How do we?
If I understand this correctly, it's really kind of trying to understand how do you actually incorporate historical information on communities, right? Communities and their relationship with policies. Tuskegee probably comes to your mind, right? I assume. So the approach that we took for the Oropuche work was a bottom up, in the sense that we were working with local diagnostic facilities that are embedded in small communities to co-create strategies on how to reach populations and use the diagnostic tools that we had to see if we can actually capture more cases and educate the populations in perhaps more modern ways of protecting themselves, in this case against the midge that is fastly disseminating. The other thing that we're doing is we're actually working with sociologists, psychologists, and economists to understand that strategy of incentives, right? And incentives are not always monetary incentives, but really kind of community-specific incentives of, if I do this, I'll protect my family, I'll protect my community, and what you get out of that, right? So to go back to Sanjay's talk, is creating your personal utility function or your community utility function, what you gain out of something by doing a particular behavior. So we've been really, and I guess I learned a lot of that while I was at Rockefeller, which is really this idea that, policy works top down, but the implementation actually is bottom up, and no implementation strategy works if you're not working with the communities. And the communities here can be like the state health department, can be community leaders, religious leaders, tribal leaders, depending on the community. And that has been our strategy. The US is a little bit tricky for all the reasons that we know. But it really, I think that it really always has that solution of, you can't really make people or communities do something just because you tell them it's the right thing to do. And that has been our strategy, is to understand what are the things that these communities or individuals value most, and see how we can create an incentive such that they don't really violate what they value most, but still work towards protecting themselves, but also their community. It sounds very world peace, kind of like I'm giving you my Miss Universe answer, I feel like, right? But at the same time, it's been our strategy that even model-wise, we can create shiny models, pretty pictures, but if we don't actually translate that into an action that creates some sort of things that communities value, they're not incentivized to do so.
I have a question for Michael. One of the parts of your talk talked about maybe you need to think about misinformation in terms of the standpoint of evolutionary biology. And I was curious, like from evolution, you've got like origin of new ideas, but then also like evolution of the ideas that already exist. And I was wondering with like misinformation, if it's driven more by like evolution of these conspiracy type ideas, or is it like the pop up of new kind of conspiracy ideas that catch hold?
Yeah, and I think our sense of using evolutionary biology is just to help people understand vulnerability, and because there's a big question about what makes someone vulnerable to misinformation, and I think a lot of times we think about cognitive bias, we think about people not having a certain educational attainment, and we think that if we just present people with facts, then that will dispel the misinformation. But that's actually not true. Fact checking is really limited, and that people are oftentimes very incentivized to believe or propagate certain pieces of information. And so when we think about it from an evolutionary perspective, we really are just trying to think about it in terms of like a fitness landscape. What information succeeds, what information doesn't, what information is ends up reproducing. That's a function of the environment. But we want to call attention to basically the game, that some of this, what we would call misinformation or not true, is incredibly useful for, I mean, it's depressing to say, but information is not always useful to people because it is true. It is useful to people in all kinds of other ways. And so it's meant as a call to think about other ways to model that. And I think when it comes down to the context of, infectious disease, being able to understand that if something is propagating or if there's just a high amplitude of conversation about it, then that is indicative of something important. Either, people are sharing it because they resonate with it, or it is a target. If it's inauthentic behavior and someone's trying to spread this material, oftentimes this is in a response because it appears to be, a kind of message that is aimed, if it's a very deliberate kind of disinformation attack, then it's targeting people in a very specific way. We think about political polarization as something that is the result of mis and disinformation, but it's actually the prerequisite for mis and disinformation, or for certain levels or amplitudes of mis and disinformation. So it is made to make our understanding of what the relationship is between bad information and human behavior more complex. How to pass that into an infectious disease model, right? Like, obviously that is, more complicated than just, changing a single parameter. But that's the main force of that argument about trying to think about things from a more evolutionary perspective rather than infectious.
I think we have time for one more question from the audience.
So I have another question for Michael. I was wondering if you could speak a little bit on the analogy between like physical geography and like the virtual space. Like, for example, like ideas can spread quicker in virtual space, but maybe things like language barriers make an interesting sort of topology to the virtual space as well.
Yeah, I think language barriers and even platform contingencies are what actually form the boundaries in virtual space, as opposed to, and then, people. Yeah, it's actually really interesting, right? This is one of the bummers of using social media data, is that the internet and social media platforms in 2020, 2021, and 2022 were really different than they are now. And so, to your point, I think we would, the geography of social media and the geography of the internet, if I could, looks very different. And I think, podcasts and other kinds of online influencers have changed the landscape of material online. I think if we were to do this today, we might not look to Twitter as where we get our information, or where we try to, like, as the sole kind of source for our sample rate. It's never the best idea, but the COVID-19 stream provided by Twitter is a resource that we're not going to pass up, and we do want to look at, even though we don't want to overly rely on them. And so, yeah, I think whereas there can be some boundaries that make a little intuitive sense to us in terms of physical and kind of cultural spaces in the quote unquote real world, I think we have to attend to just the shifting geographies of the online environment. And I think that has to be packaged into any kind of, information environment rating. I think the scale has to be appropriate to wherever the model's running. But that's why I feel like it's inescapable that there's going to be some qualitative data analysis associated with some of this stuff, and it can't just all be quantitative to be able to rate that information environment. I think there's too many complexities involved to just leave it up to counting some bits of metadata and then calling it a score.
Well, I just want to thank all of our speakers again from this session. Thanks so much. And I also want to thank Nick, Steve, and Cindy for organizing this event. So